હા શ્રેયાંશ એકવાર ફ્રી થાય તો જોઈ લેજો એંગલ ને બધું બરાબર છે ને, કારણ કે પેલામાં ચેનલ બંધ થઈ ગઈ છે, તમે બીજી ચેનલમાં ચાલુ કરી છે એવું છે. હા એટલે ખાલી એકવાર ફ્રી થઈને જોઈ લેજો ને. હેલો એ સારું.
Good morning, everyone. Welcome on this Sunday morning. And, thank you for spending your time on this holiday. So, hoping that everyone will have involvement in this. I will not say this is a lecture series. This is just a discussion. We all will have discussion on various issues of specifically shoulder joint. So, the entire theme of this day is to have various difficult scenarios related to shoulder joint, clearing basics to advanced, uh, covering maximum topic as far as possible. And we have esteemed faculties today who have immense experience in this field, so try to grab as much as possible. This entire event has been organized by the Zydus Hospital as well as Abhinav Bindra Foundation. Abhinav Bindra Foundation has been working all over India to create awareness specifically for the sports injuries, injury prevention, after surgery rehabilitation. So we have a tie with them, and from the Abhinav Bindra Foundation we have Miss Bhagyashree Sawant. She is from Mumbai, but basically she is working in Bangalore right now. She was a national rugby player. She has climbed Mount Everest. She is a Guinness Book record holder for cycling all across India. She has been undergone various surgeries for many ligament injuries. Still, she is running marathon and coming in top three in various cities across India. So first, I'll welcome Bhagyashree Sawant to introduce her and give some basic talk regarding sports injuries.
Very good morning to everyone. Everyone sleepy here? Can't hear the good morning at all. A very good morning to one and all present here.
Good morning.
Okay, perfect. Because since you all are physiotherapists, I'm sorry I've lost my voice, please bear with me. Since you all are physiotherapists and you are really going to play a major pivoting role. Check. Yeah. So you all are going to play a major pivoting role in a lot of career of a lot of athletes, and it's very much important that you all also stay energetic throughout the session because today we are going to see we're going to learn a lot of things about what's going to happen in today's session. So to begin with, yes, as Dr. Rohan rightly mentioned, we are focusing along with Abhinav Bindra Foundation, also powered by Ceramics. We are trying to build a healthy sports ecosystem across India because what's happening everywhere is the Indian sports industry is really growing very fast. Name it any sport, whether it is rugby, it's football, cricket, tennis, table tennis, kabaddi, athletics, and all these sports are getting all pro leagues right now. And you must be even watching over the televisions, over a lot of other sessions as well, of how the physiotherapists are playing a crucial role in this. Earlier, even when you see Team India, it used to be only the coach and the player used to travel with the team. Now we have the coach, we have the teammates, we have the players, we have the physiotherapists, we also have the nutritionists and the psychologists traveling with the teams. Why? Because all of that has been playing a pivoting role over here. So of course today's session focusing on shoulder injuries, especially sports specific protocols, is because for an athlete, a lot of other factors also that play a role. And it may be interrelated to each other, it may not be interrelated to each other. But coming to injuries, how to prevent them, performance pressure, which can lead them to loss of career, which can again cause them emotional distress, which can cause physical distress to them, and then again the treatment options that most of the athletes in India are not aware about. So that is the reason why you all as physiotherapists would be playing a very crucial pivoting role over here because you will be focusing on athletes recovery. Now when we say athletes recovery, it's not only about recovery after an injury, it's also recovery during the training because after every training session, the physiotherapy sessions are much needed. Then the rehabilitation, the kind of infrastructure we have, the support we give, the development of the talent at the grassroots level itself, all focusing on helping the athlete to come back. So what we do under the Sport of Life campaign with Abhinav Bindra Foundation is we have signed up with 30 top doctors across India, 30 top sports medicine doctors across India rather I would say, of which in Ahmedabad we have signed up with Dr. Rohan Vakta. The main thing under this campaign what we try to do is we try to work on upliftment of underprivileged athletes. So if there's any athlete who has to undergo a shoulder or a knee surgery, cannot afford it due to his or her financial status, that's where Dr. Rohan Vakta has agreed to waive off his doctor's fee, while the company named Ceronics would be giving the medical implants free of cost, due to which the surgery for an athlete is going to be much affordable. So through this program, we have a lot of other initiatives where we have awareness, we have injury prevention. I'll come to both the programs, and these are the kind of initiatives we're taking care under this campaign. As I said, there are two programs that we take care. One is Dugout, which targets only the athlete audience. In the Dugout program, we've done almost around a couple of Dugout programs in Ahmedabad with Dr. Rohan as well. We tell the athletes on how they can prevent injuries, how they can manage injuries, how they can cope up with it, how they can come back uh, after an injury, after any treatment to the sport. And the second one, which is our today's session, that is Rebound, because as physiotherapists, when you're dealing with the general public and when you're dealing with the athletes, it's going to be totally different, because the aim for an athlete is not just to stand or walk back. The aim for an athlete is more intense. He has to jump back, he has to get back into his sports, he has to perform at his optimum level. So that is the reason why we have this program called as Rebound Ahmedabad, the first ever rebound program ever that we're having with Zydus Hospital, with Dr. Rohan Vakta and with Abhinav Indra Foundation right here. So yes, I'll just take about 2 minutes to narrate my story of how physiotherapy played a very important role. As an athlete, I've always been injury prone. No matter what it is, even if you ask me to walk here, probably I will end up falling. That's kind of a person I am. So while I was playing rugby for Bombay Gymkhana in Mumbai, I had a fall on my right knee, and I didn't even know what ACL or ligaments were that time, because as an athlete, I only knew how to play, how to run, how to jump. And rugby being a contact game by itself, after having a fall, the mistake I did is I stood up, I tried to run again. Why? Because my coach and my friends told me it's okay, it's just a fall, run. The very next step I took, I literally heard a sound of a cloth tearing right from my knee. I didn't know what it was. I tried to continue, then I couldn't walk for the next few days. After getting diagnosed, after getting the MRI done, I realized it was an ACL tear. And that's when my entire perspective in life changed, because I've been a mountaineer myself. I climbed Mount Everest twice till 8,000 meters. And mountains taught me a lot of things to be resilient and to accept things the way they are. I started appreciating my injury, I started celebrating it, because a happy mind definitely is something that helped me get moving. And yes, as you can see, Dr. Rohan Vakta is also there. I celebrated my surgery, cutting a cake with my surgeons, because it was a new experience for me. But trust me, all this mentally took a lot of toll in a positive way on the complete journey. So while going to Everest, of course, it's not that you just get a one fine day and then you go there to the mountain, you start climbing. It's not like that. There's a lot of preparations that we had to do, right from let's say when you what is it that reduces in the air when you go higher at an altitude? Oxygen. Nobody sounded confident about it, or maybe we're just conscious. Okay, yes. So as oxygen goes lower, what happens is our body also, our metabolism also takes a toll on us. So that is the reason why before going to Everest, I had to prepare my body in all the dimensions. One is mentally. Why? Because mental endurance is very much important. Second, physically. When I say physically, I used to go to high altitude chambers in Mumbai where the oxygen was set at 13%. And that is where I used to train. I used to try to stimulate the entire environment. And most importantly, training my muscles. Why? Because it's not just my legs that are climbing. This, what you can see, is still hiking. Till base camp, you only hike. But after the base camp, it is all technical climbing, where we have to use our shoulders, we have to use our arm and upper body strength. When I went to Everest, my weight was 54 kgs. When I got back, my weight was 36 kgs. Just sitting at a place and doing all this hard work on the mountain, I started burning my calories right there. My gear itself is about 80 kgs, and to carry 80 kgs on my shoulder one time, it's not possible. We had to take multiple rounds on the mountains, and this is where my physiotherapy played a very major important role. In fact, I was with Dr. Ali Rani in Mumbai, who helped me to get myself trained for the complete physiotherapy session. For 6 months, I underwent physiotherapy, strength and conditioning, because I had to condition my muscles and stimulate them for this environment. So this was some glimpses of Everest, and That is where our daily backpacks and crevices are. That's one of the most beautiful part of Everest, and also the most risky part of Mount Everest. It's called as Kumbu Ice Fall. They are the ice blocks. On the right hand, what you can see are the crevices. So if you fall in the crevice, it's very difficult for you to come back out. So knowing all of this also, we still continue in the sport. Similarly, every sport has its very own risk, and it's important not to scare any athlete, but rather, as physiotherapists, you all be with him, build his or her confidence that we are with you in this journey. We are going to help you provide and prepare with whatever is necessary for you to prepare for your entire journey. So yes, with this my Everest journey had come to an end, and after that, in fact, I had my ACL ligament injury and a reconstruction. A lot of athletes, a lot of friends, a lot of family members, relatives told me, "You've just undergone a surgery. No more playing sports. Enough. Focus on your life. Blah blah blah." And that's where a lot of your clients also going to come with that mindset. Whether should I continue back in sports? I've had an injury. I've had a major surgery. You think I can come back? That's where you all are supposed to give them that confidence. When people told me you're not fit to run, you should not do this, you should not continue sport anymore, that's where I defined, I pledged to prove them wrong. I decided to cycle across the country, starting from Himachal Pradesh, a small town called Palampur. I cycled to 400 government schools across India, and this entire journey I started from Himachal, Punjab, Chandigarh, Haryana, Delhi, Uttar Pradesh, Uttarakhand, Bihar, Jharkhand, West Bengal, Assam, Dadra Nagar Haveli, Daman and Diu, then going to Andhra Pradesh, Tamil Nadu, Kerala, Bangalore, Goa, and again finishing in Karnataka. The entire journey took 183 days, that is 6 months. I managed to cover 18 states, 5 union territories, 19,400 kilometers, breaking an existing Guinness World Record of an Australian by 600 kilometers. And all this was only possible because of all the zeal, the passion, the post surgical rehabilitation and recovery that I did. The whole purpose of this campaign also is that we don't want the sport of life for any athlete to ever stop. Not just athlete, but even when you see the when you address the general public, the sport of life is even as basic as getting up from your bed, going and doing your daily course, and even walking, which has been a struggle for you. So, wishing you all a happy learning experience today, and I'm sure that with all the emerging future therapists and sports physios over here, today's Shoulder 360 is going to be an amazing platform for all of you to learn. So all the best. Over to you, Dr. Rohan.
It was an excellent, motivating talk to start the today's day, Bhagya. So, as she rightly mentioned, physiotherapy, especially in our country, the role of physiotherapist is not only to give a proper exercise, but as a motivational supporter also. Sometimes physiotherapists play important psychology support, as well as I have seen many physios over here who give advice regarding diet, nutrition, and other medical treatment also. So now we are starting with the different shoulder topics, starting with shoulder biomechanics. Before we start today's session, I would request everyone to stand up for our national anthem, then we start today's session.
अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्छल जगति तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगल दायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
before we start today's session, this our entire focus is shoulder joint, but we have to understand that our body is just like our universe. If we see our solar system, all the planets, the sun, moon, everything is interrelated. Since millions of years, they are moving in the same directions. All of them are interconnected. Similarly, our body is also interconnected. So, since we are focusing on the shoulder joint, it is important that we don't only focus like Arjun's eye only on the shoulder. We first focus on the entire body. Along with we focus on the particular disease joint. If we are focusing on the knee joint, similarly we focus on the other parts also. So it is very important that entire our body is like universe interconnected. As you better know than me that it is entirely connected like a kinetic chain. If we see the great sports players, for example Roger Federer, he has been serving 160 miles per hour speed without, if you see his career of 25 years, we have not seen him having shoulder injuries quite often. Why? If we see his shoulder, it's not very muscular. Still, he is able to generate that force because of his alignment, his biomechanics, and proper techniques. So, along with the good biomechanics, technique, overall fitness of the body is more important. So, before we proceed, it is understand that it is better to understand the entire biomechanics of the body. And if you just taking an example of this overhead athlete, if you see this entire body is coming into the play while jumping, while landing, balancing to avoid the injury. So shoulder is highly mobile joint, but the mobility comes at the cost of stability. So we see a lot of instability also. So why shoulder problems are increasing? So we are engaging into many overhead sports. Shoulder is a non-weight bearing joints, but we are engaging into hyperangulation sports, stretching the normal physiological range, doing weight bearing activities of the shoulder joint. Many road traffic accidents, contact sports, collision injuries. So, which common pathologies we encounter in day-to-day practice, like subacromial space related, like subacromial impingement, rotator cuff pathologies, rotator cuff tendinitis, tear, labral related pathologies like labral detachment, slap tear, Bankart lesions, ligament injuries, AC joint ligament injuries, glenohumeral ligament injuries, and capsules like capsular tightness, which we call adhesive capsulitis. So we will discuss all of these conditions today. So before we begin, I would introduce Dr. Nikuj Bekaria from Civil Physiotherapy College. He is a senior lecturer there, a very vast experience. He will take one of the most important topic of today, that is biomechanics of the shoulder joint. Welcome.
So good morning everyone.
Good morning, sir.
I am sure that whatever I am going to say today is nothing new to you because biomechanics is a very basic. But before going to detail in the examination and rehabilitation protocol, we must know the basics of shoulder, that is biomechanics. So all we know there are three participating bones: clavicle, scapula, and humerus. There are four joints: sternoclavicular, acromioclavicular, glenohumeral, and scapulothoracic. I am not going much in detail about the osseous and ligamentous portions. I am going to take portions which are important to us physiotherapists, that is dynamic stability and static stability of the shoulder joint. Position of scapula, we are knowing that spine of the scapula at the level of T2, inferior angle at the level of T7, it lies 2 inches from the midline. It positions slightly anterior to the frontal plane, that is internally rotated 30 to 45 degree, and 10 to 20 degree anteriorly tipped and slightly upwardly rotated. As we all know, glenohumeral joint, ball and socket joint, and sir already said that it is a highly mobile joint, but at the cost of stability. Now directly coming to the static stabilization. Static stabilization means when our arm is in the dependent positions, when just we are simply it is in the dependent positions. Gravity continuously pulls the arm into the downward direction. So to maintain that force in the downward direction force, any force which can vertically pull or which can stable the shoulder joint is needed to maintain the equilibrium at the normal dependent arm position. So there are four mechanisms are there. First mechanism is that as you can see in the figure, gravity continuously pulling the upper extremity in the downward direction, and because of that pull, the passive tension is created in the rotator cuff interval capsule. So resultant force of that passive tension and gravity, which can compress the which can compress the head of humerus into the glenoid fossa, which provides the stability to the joint. The second mechanism is in healthy glenohumeral capsule. It has a airtight seal which create a negative intra-articular pressure, which create a vacuum. So that vacuum is resist the inferior translation of the inferior translation of the head of the humerus because of the gravity. The third mechanism is the position of the glenoid fossa itself. As I have already told that the scapular position is slightly upwardly rotated. So that upward rotation of the scapula and head of humerus, it creates a partial bony block to the head of humerus and inferior portion of the glenoid cavity. So it also provides the stability. And the last is supraspinatus and subscapularis muscles. As many studies have shown that there is no electrical activity in the electromyography during the just dependent arm position in the supraspinatus. But when you see the patients of the paralytic patient, if you see there is a paralysis of the supraspinatus and upper trapezius, the slight inferior dislocation, definitely you can see the sulcus sign and all that in the chronic patients of the paralysis. Next very important aspect is dynamic stabilization. So as first when we talk about the elevation, we talk about the abduction. First, the muscle which come into our mind is deltoid. Deltoid is the prime mover for the elevation, abduction. Okay. But if you see closely the biomechanics of deltoid, if you see the line of action of pull of deltoid, the red line is the deltoid action of pull. If you closely observe that the deltoid, if activates alone, it will pull the head of humerus superiorly. It will translate superiorly. So what will happen? It will translate superiorly. Deltoid has a very less momentum for the abduction. Okay, very less momentum for the abduction. So if deltoid alone, if it activates, it will translate head superiorly. So what will happen? Head will stuck with the acromion process. So what will happen? The structures between the head of humerus and acromion process will get compressed. Okay. So for the abduction movement, any other force is required which can provide the further mechanical advantage, which can pull the humerus in the abduction than superior translation. So next comes into picture supraspinatus. Supraspinatus, if you closely observe the supraspinatus line of pull, it divided into two parts with the momentum for the abduction is larger than the deltoid. Though it can produce a less force than the deltoid, but the momentum for the abduction moment is larger than the deltoid. So when the supraspinatus comes into the picture, it can slightly elevate the arm. After that, deltoid can pull the arm in the abduction. Okay. Now both the muscles, see the deltoid also has a superior pull and supraspinatus also has a superior pull. So only if these two muscles will activate, what will happen? Look at my hand. This consider this as a head of humerus and this is the glenoid cavity. Deltoid and supraspinatus both will activate. The abduction will happen. Definitely, abduction will happen. But along with the abduction, both the muscles, they can superiorly translate the head of humerus. So along with the abduction, the head of humerus will translate superiorly. So contact between the glenoid fossa and head of humerus will continuously decreasing, as well as the acromial space also will be decreasing because of the superior translation. Okay, so what another force is needed to maintain the contact between the head of humerus and glenoid fossa. The another force is needed to pull the head in the downward direction. So when the head will be pulled in the downward direction during the abduction, the contact throughout the movement will be maintained between the glenoid cavity and head of humerus, and the subacromial space also will be the maintained. So there will be no chances of impingement between the structures in the subacromial space. So third force which is needed, which can pull the head of humerus in the downward direction, that comes into picture. There are three muscles: infraspinatus, another three muscles of rotator cuff: infraspinatus, teres minor, and subscapularis. If you see the resultant pull of these three muscles, the red line, you can see the all the three muscles can downwardly caudally pull the head of humerus, as well as they can compress the head of humerus into the glenoid fossa. So it provides further stability to the joint, as well as it can caudally glide the head of humerus. So deltoid and resultant force of the deltoid and all the rotator cuff muscles result into the smooth abduction and full range of motion without any impingement and all that. So these are the force couple effect between the first force couple effect we have seen between the deltoid and supraspinatus. Deltoid and supraspinatus both can abduct the arm, and another force couple effect between the deltoid and another three rotator cuff rotator cuff muscles, subscapularis, infraspinatus, and teres minor muscles. The another dynamic stabilization provided by the long head of biceps, so it also runs anterolaterally, which can pull the head into the slightly, which can pull the which can push the head into the center of the glenoid fossa. Now, what we have talked till now is about the movement of the humerus only. Barabar. I have not talked about the movement of the glenoid fossa, which is a part of scapula. As we all know, the upper extremity movement is a it requires movement of all the joints. What I have told earlier: scapulothoracic joint, acromyoclavicular joint, sternoclavicular, and glenohumeral joint. So as we all know that the scapulohumeral rhythm, in the first phase, humerus moves a 30-degree, scapula mostly there will be no movement, or that we can call the setting up phase for the fascicula for the scapula. In the second phase, humerus moves 40 degree of abduction, and the scapula started to move also 20 degree of upward rotation, 20 degree of upward rotation, and clavicles also come into picture. Clavicle also need to elevate. The third last phase is 50 to 60 degree of shoulder abduction, and the scapula 30 to 40 degree of upward rotation. And lastly, clavicle also need to upward rotate, plus to complete the movement laterally, posterior rotation of clavicle, which is done by the only one ligament is there in the body which can create the movement. This is that is trapezoid part of the coracoclavicular ligament, which can create the posterior rotation of the clavicle. Okay, now this, so which movement is needed, that we have already discussed about the humerus movement. Another movement is needed along with the humerus is scapular upward rotation. So for the scapular upward rotation, another force couple effects are there in the scapular muscles. The first we will discuss about the trapezius. The trapezius is a three part, as we all know: upper trapezius, lower trapezius, and middle trapezius. First we will discuss about the upper and lower trapezius. Upper trapezius can do the elevation and upward rotation. Lower trapezius can do the depression and upward rotation. So resultant force of the upper and lower trapezius produce a force couple effect and move the scapula in upward direction. The next, middle trapezius can adduct the scapulae. So as a whole, trapezius can adduct the scapulae and upwardly rotate the scapulae. Okay. So during the elevation, as we have seen, during the elevation, what we need is upward rotation only. We don't need adduction of the scapula. So to balance the adduction momentum of the scapula trapezius, we need another muscle where serratus anterior comes into the picture. Serratus anterior has a two action. Serratus anterior also can upwardly rotate the scapulae and abduct the scapulae. What trapezius can do? Adduct the scapula and upward rotation. What serratus anterior can do? abduction and upper rotation. So adduction and abduction moment are both the balance each other, and resultant force will rotate the scapula in upper direction. The muscles of elevation already we have discussed. Deltoid alone, if it alone deltoid if activates, it translates the superiorly, it translates the humerus superiorly. So along with the rotator cuff muscle, deltoid can do the abduction. Anterior portion of deltoid, we know that it is a prime mover for flexion. Middle portion is prime mover for abduction. The posterior deltoid has a very less momentum for the abduction in the frontal plane. Now this is also very important. If scapula, what happen if the scapula is restricted to complete the elevation, glenohumeral joint, to complete the elevation, to complete the abduction or flexion, along with the humerus, the scapula also should rotate. Okay. If scapula will not rotate, what will happen? The deltoid arise from the scapula and insert at humerus. Okay. So when the scapula also rotates, the length of the muscle during the contraction will be maintained throughout the movement. If the length will shorten, what will happen? Active insufficiency. Active insufficiency means when the muscle becomes shortened, it is unable to produce a sufficient force. So scapula will not rotate. So what will happen? The deltoid will become more shorter and it cannot produce a efficient, effective amount of force, which you cannot complete the full range of motion. The another possible scenario is if scapula is not stable or scapula is restricted, the humerus is heavier than the scapula. So what will happen if scapula is not stable? The deltoid, it should act on the humerus, but humerus is heavier than the scapula. Scapula is not stable. What will happen? The deltoid, it will not act on the humerus, but it will act on the scapula, and it will move the scapula, which also affect the movement, which also affect the excitability of the muscles. Next, already we have seen the function of the supraspinatus sac. It can compress, it act as a steerer, it maintains the stability in the dependent arm. The important thing is it has a larger moment arm than the deltoid to start the abduction. This also already we have discussed. Infraspinatus, teres minor and subcapularis muscles. All the three muscles simultaneously activates, and it can compress the joint. It can downwardly pull the glenoid fossa to complete the abduction without any impingement. In all these three muscles, the early peak we can see from 0 degree to 150 degree. At the angle of 115 degree, the activity in the infraspinatus rises to laterally rotate the arm to complete the elevation. Without lateral rotation, we cannot complete the abduction. Okay, because the greater tuberosity and acromion process will stuck without lateral rotation. This force couple also we have already discussed. Upper and lower trapezius both can combinedly work, and it can upperly rotate, and trapezius and serratus also it can upperly rotate the scapula. The important thing is that serratus anterior lies in the frontal. If you see the muscle fiber, the alignment of the muscle fiber, it lies in the frontal plane. If you see the trapezius, if you see the serratus anterior, it lies in the sagittal plane. Okay, so why this is important? When you are doing movement of the frontal plane movement means abduction. Sagittal plane movement means flexion. When you are doing movement of the frontal plane, the muscle lies in the frontal plane will get recruited more. So what I am going to say, during abduction, trapezius works more than serratus anterior, and during flexion, the serratus anterior, which is more aligned vertically, which is more aligned with the sagittal plane, which activates more during the flexion. If you see the manual muscle testing in our books, the positions which are derived for the manual muscle testing to assess the serratus anterior and to assess the trapezius, they have kept the arm in the frontal plane for the trapezius muscle tilting, and for the serratus entry at the position they have described is try to hold the 110 degree of flexion. So flexion is in the sagittal position to check the muscle of to check the serratus anterior muscle. Okay, so when you are doing the movement of frontal plane, the muscle aligned in the frontal plane, that is trapezius, it recruited more than the sagittal plane muscle, and when you are doing the flexion, the serratus anterior is going to recruited more than the trapezius. So what will happen when the trapezius muscle is paralyzed? Trapezial muscle is paralyzed, it will not affect the active range of motion of flexion, because in the flexion which muscle is recruited more? Serratus anterior. Okay. So trapezius muscle is paralyzed, active range of motion of abduction will affected, but flexion will not be affected. Same vice versa, when the serratus anterior muscle is paralyzed, active flexion will be affected, but active abduction will be weaker, but active abduction will not be affected as a range. Okay, range you can complete the range, but though it is a weaker motion. Now next muscle is rhomboid. Rhomboid also we can rhomboid as a muscle. If you see the action, it can downwardly rotate the scapula. Downwardly rotate the scapula. But rhomboid, if you see the function of rhomboid, what will rhomboid do during the upward rotation of the scapula? The rhomboid eccentrically work to control the movement of scapula. If rhomboid will not work, the movement, that scapulohumeral rhythm will be disturbed. Upward rotation will be more. Okay. Now last is muscle of depression. As we all know, the muscles of depression are latissimus dorsi and pectoralis major muscles. When these muscles come into picture as and in open kinematic chain, we all know that actions of latissimus dorsi, extension, medial rotation. But when it is important to us, when it is important to physiotherapist, when we need to train the depressor muscles, when your lower extremity muscles are weak, when you getting up from the chair with the help of upper extremity, when you want your upper extremity in weight, you want to use your upper extremity in weight bearing position. If you have a fracture of lower limb and non-weight bearing gait with the crutch, so what will happen when you walk with the walker or crutch? When you give weight on the crutch, the reaction force of the crutch or walker will give to your shoulder, which will elevate your shoulder. So to stabilize the shoulder, the two muscles come into the picture, that is latissimus dorsi and pectoralis major. So in all the lower extremity cases, in all the non-weight bearing gait training cases, we need to train the latissimus dorsi and pectoralis major to avoid the shoulder pain. Otherwise, you will the patient will complain after some period of time that I have a shoulder pain after with walking with the crutch. Next muscle is teres major and rhomboid. Teres major also it can adduct, medially rotate and extend the humerus, but the rhomboid muscles, when it will provide stability to the scapula, then only teres major muscle arise from the scapula and act on the humerus. Okay, act on the humerus. But when it can act on the humerus, when the scapula will be stable. But if the scapula is not stable, then the muscle will act on the scapula itself and instead of humerus. It cannot act on the humerus because humerus is heavier. So rhomboid will provide stability to the scapula, it will provide base to the scapula, and after that teres major muscle can work on the humerus. These all are the muscles we have already discussed. This line of pull of the muscles. So lastly, કાઠિયાવાડમાં ડાયરામાં લોક ડાયરો થાય ને એમાં ઘણી વખત એવી વાત થતી હોય છે કે ક્યારે બોલવું હોય તો બધાને ખબર છે, બરાબર, ક્યારે કોકને સલાહ આપીએ બધાને ખબર છે, ક્યારે ના બોલવું ને એ કોકને જ ખબર હોય. બહુ ઓછા લોકોને ખબર હોય કે આપણે ક્યારે ચૂપ રહેવું, મૂંગા રહેવું જોઈએ, એવું કોકને ખબર. એવી જ રીતે ક્યારે કઈ ટ્રીટમેન્ટ આપી એ તો આપણને ટ્રીટમેન્ટ બધાને બધા પ્રોટોકોલ ખબર છે, પણ કઈ મુવમેન્ટ નથી કરાવવાની, એ સ્પેશિયલી પોસ્ટ ઓપરેટિવ કેસમાં શું નથી કરાવવાનું, ધેટ ઇઝ વેરી મચ ઇમ્પોર્ટન્ટ. અને એ આપણે બાયોમિકેનિક્સ ઉપરથી ડેફિનેટલી વી કેન કમ ટુ ધ કન્ક્લુઝન કે વિચ ઓલ મુવમેન્ટ્સ વી શુડ રિસ્ટ્રિક્ટ, બરાબર, અને કયા મસલ્સ ઉપર બી આપણે વધારે એમ્ફેસિસ આપવું જોઈએ. Okay, thank you.
Excellent talk, Nitin sir. Just a few questions from my side. Just few questions. As you rightly said કે which કઈ movement ના કરવી જોઈએ પણ તમે ફિઝિયોથેરાપી પર્સપેક્ટિવથી કીધું કે આ એક્સરસાઇઝ પર વધારે ફોકસ કરવું જોઈએ. અમે એઝ અ ઓર્થોપેડિક વાત કરીએ તો અમને જે મેજર ઇશ્યુ નડી રહ્યો છે કે કોઈ પેશન્ટની હ્યુમરસ પ્લેટિંગની સર્જરી થઈ કે રોટેટર કફ સર્જરી થઈ અને ફોન ઉપર અમે અમારા ફિઝિયો જોડે ડિસ્કસ કરીએ કે પેશન્ટના રિલેટિવ જોડે પૂછીએ કે કેવું છે તો કે સાહેબ બહુ સારું છે 90 ડિગ્રી મૂવમેન્ટ આવી ગઈ આ રીતે 90 ડિગ્રી મૂવમેન્ટ આવી ગઈ સો દેટ ઇઝ ધ મેજર ઇશ્યુ કે દે ડોન્ટ નો કે ધીસ ઇઝ નોટ 90 ડિગ્રી 90 ડિગ્રી ગ્લિનોહ્યુમરલ પછી સ્કેપ્યુલોથોરેસિક એ હજુ નથી તો આઈ વુડ રિક્વેસ્ટ કે તમે એક વોલન્ટિયર પર ખાલી ડેમોન્સ્ટ્રેટ કરીને બતાવો કે 0 to 90 ગ્લિનોહ્યુમરલ કઈ કહેવાય પછી સ્કેપ્યુલોથોરેસિક કઈ મૂવમેન્ટ હોય અને તમે સ્કેપ્યુલર સ્ટેબિલાઇઝ કરવા માટે જસ્ટ શું વધારે કરતા હો છો કાઠિયાવાડી લોકોના માઇકની જરૂર નથી
સર બહુ સરસ સવાલ પૂછ્યો છે. આપણે મુવમેન્ટ સરે ઓલરેડી પરફોર્મ કરીને બતાવ્યું આવી રીતે આમ કરી બરાબર. મોસ્ટ ઓફ ધ શોલ્ડર કેસીસમાં તમે જોશો પેશન્ટને એબડક્શન કરાવશો ને આવી રીતે કરશે. કેવી રીતે આવી રીતે અને છતાં પણ તમે લોંગ ગ્રેવિટી આપણે ફૂલ લીવરમાં અગેન્સ્ટ ગ્રેવિટી આપણે ફૂલ રેન્જ એબડક્શન અચીવ કરવાનો પ્રયત્ન કરશું એ જે પોસિબલ નથી. પહેલા તો સરે કીધું એમ નોર્મલ રેન્જ ઓફ મોશન શું છે ઓલરેડી આઈ ટોલ્ડ યુ સ્કેપ્યુલોહ્યુમરલ રિધમ 0 to 30 ડિગ્રીમાં ખાલી ગ્લેનોહ્યુમરલ જોઈન્ટનું જ એબડક્શન થાય છે બરાબર. એના પછી સ્કેપ્યુલા વિલ કમ ઇનટુ ધ પિક્ચર. પછી ફેઝ 2 માં સ્કેપ્યુલા અને હ્યુમરસ બંનેનું લેટરલ રોટેટ બંનેનું સાથે મૂવમેન્ટ થશે એબડક્શન થશે અને સાથે સ્કેપ્યુલાનું અપવર્ડ રોટેશન થશે બરાબર. અને અપવર્ડ રોટેશન કન્ટિન્યુ રહેશે છેક સુધી સાથે મૂવમેન્ટ પણ જોડે ને જોડે એલિવેશન થશે અને લાસ્ટ થર્ડ ફેઝમાં ક્લેવિકલનું પોસ્ટિરિયર રોટેશન થશે બરાબર. પણ આવું જ્યારે થતું હોય ત્યારે એના ઘણા બધા રીઝન હોય છે. જ્યારે પણ આવી રીતે એલિવેશન કરીને પેશન્ટ કરતું હોય ત્યારે શું હોઈ શકે એક તો સૌથી પહેલા બાયોમેકેનિક્સમાં આપણે ડિસ્કસ કર્યું એમ ઇન્ફ્રાસ્પાઇનેટસ ટીરીસ માઇનર અને સબસ્કેપ્યુલારિસ એ ત્રણ મસલ્સ એવા છે જ્યારે હેડ ઓફ હ્યુમરસ ઉપર એલિવેટ થતું હોય ત્યારે એને ઇન્ફિરિયર પુલ એટલે નીચેની તરફ ખેંચવા માટે એ ત્રણ મસલ છે. કોડલ ગ્લાઇડ આપવા માટે કોડલ પુલ કરવા માટે એ ત્રણ મસલ્સ જ વીક હોય તો શું થશે જેટલી વખત તમે એબડક્શન કરશો એટલી વખત શોલ્ડર એલિવેટ થઈ જશે. એ જેટલી વખત શોલ્ડર એલિવેટ થશે એટલી વખત સબ એક્રોમાયલ સ્પેસમાં મસલ્સ જે છે સોફ્ટ ટિશ્યુઝ છે બરસા છે એ બધા ઇમ્પિંચ થશે. જેટલી વાર ઇમ્પિંચ થશે એટલી વાર એનું ઇન્ફ્લામેશન જશે જ નહીં એટલે પેશન્ટની પેઇનની કમ્પ્લેન કોઈ દિવસ જશે બરાબર. એટલે ઇમ્પોર્ટન્ટ છે ટુ ગ્રુપ ઓફ મસલ્સ. એક આપણે હ્યુમરસની જ્યારે વાત કરીએ ત્યારે રોટેટર ગ્રુપ ઓફ મસલ્સ જે which provide the compression to the glenohumeral joint અને which can pull the head of humerus caudally બરાબર. એટલે રોટેટર કફ મસલ્સનું સ્ટ્રેન્થનિંગ બહુ ઇમ્પોર્ટન્ટ છે અને સાથે ને સાથે સ્કેપ્યુલર મસલ્સ ખાલી એકલું હ્યુમરસને ડાઉનવર્ડ ડિરેક્શનમાં પુલ કરો પણ સ્કેપ્યુલા મૂવ ના થતું હોય તો સ્કેપ્યુલા પણ આ સ્પેસ મેન્ટેન રાખવા માટે બંનેની મૂવમેન્ટ સાથે ને સાથે જરૂરી છે. સ્કેપ્યુલાનું પણ અપવર્ડ રોટેશન એટલું જ ઇમ્પોર્ટન્ટ છે. એટલે સ્કેપ્યુલાનું અપવર્ડ રોટેશન અને ફોર્સ કપલની આપણે વાત કરી તો ટ્રેપેજિયસ અને સિરેટસ એન્ટેરિયર આ બે મસલ્સ બહુ ઇમ્પોર્ટન્ટ છે. ટ્રેપેજિયસમાં અપર અને લોઅર બંને ભેગા થઈને એક ફોર્સ કપલ ઇફેક્ટ કરીને અપવર્ડ રોટેશન કરે અને હોલ ટ્રેપેજિયસ એ એડેક્શન અપવર્ડ રોટેશન કરે અને સિરેટસ એન્ટેરિયર એબડક્શન અને અપવર્ડ રોટેશન કરે. એટલે સિરેટસ એન્ટેરિયર અને ટ્રેપેજિયસ. નેક્સ્ટ અલાઇનમેન્ટ ઓફ ધ ફાઇબરમાં સિરેટસ એન્ટેરિયર જ્યારે ફ્લેક્શન મૂવમેન્ટ જ્યારે ટાર્ગેટ કરવાની હોય ત્યારે ઓલવેઝ વર્ક ઓન ધ સિરેટસ એન્ટેરિયર જ્યારે એબડક્શન મૂવમેન્ટ ટાર્ગેટ કરવાની હોય ઓલવેઝ વર્ક ઓન ધ ટ્રેપેજિયસ.
થેન્ક યુ વેરી મચ. So whenever a patient comes to you, so first now we understood the biomechanics. Now it's implementing our knowledge into practical world. Whenever a patient comes to you with shoulder pain, how do you diagnose the condition? Shoulder pain can come from the shoulder itself, from cervical spine, from chest, or many other places. So how to approach the patient when comes to you? So usually we divide it into three parts. First, listening to the patient carefully, that is taking history, understanding the symptoms pattern. Second is examining the patient. After you listen to the history, usually your differential diagnosis come into your mind. So the next comes the examination, and the last final conclusion is the imaging. In imaging, we usually do X-ray, CT, MRI. So the first part is patient symptoms, that is history and the context of the history. For the same, I would invite Dr. Amit Parikh. He is a shoulder specialist physiotherapist and a certified McKenzie therapist, to present his talk regarding the history and related to history, how to diagnose the various conditions. Amit, welcome.
Good morning, everybody. Thank you, Abhinav Miller Foundation, Zydus Hospital, and special thanks to Dr. Rohan Bhakta for inviting me and for giving me this opportunity. How many of you are clinicians? और आप में से किसको लगता है कि हिस्ट्री इज अ बोरिंग पार्ट ऑफ फिजियोथेरेपी ट्रीटमेंट? So history is a very crucial when you are dealing with a patient with shoulder problem. Without history, your diagnosis and the treatment is worthless. When a patient is coming with a shoulder injury, history gives you quality of information, and dealing with the shoulder patient, you can get provisional diagnosis, and which is laterly confirmed by examination. Or if you're looking at best thing about the shoulder joint is why patient coming to the clinic, that looking at the age of the patient, you can understand the possible conditions likely. The best thing about the shoulder joint is you can diagnose this condition by looking at the age of the patient. The conditions like instability. Usually you can see the instability patient in younger patients. They have slept head, internal impingement syndrome, and the multi-direction instability. In middle age group, that is the 30 to 50 years of age, patient are suffering from impingement syndrome, partial rotator cuff tear, incomplete tear. If patient above 50 years, they have rotator cuff injury. Patient above 60 years, they have arthritic changes like glenohumeral joint arthritis, AC joint arthritis, and rotator cuff tear, tendinopathy. Also, the occupation is important. While occupations like teacher, painter, and carpenter, they are dealing with the overhead activity. The over a period of time, the overhead activity, rotator cuff muscles are impinged under the subacromial bursa, which impinge your rotator cuff, and over a period of time it gets injured. In sports player, you are deal with labral injury, laxity, internal impingement, and later on rotator cuff tear. Software professionals and executives are dealing with postural syndromes and mechanical problems. Even the hand dominance is equally important for shoulder and upper limb trauma and atraumatic. Usually patient with trauma have history of fracture, dislocation, rotator cuff tear, while atraumatic patients have multi-direction instability, adhesive capsulitis, or postural syndrome. Onset of injuries like acute after trauma and even chronic. Usually rotator cuff patient will come with you after 3 months of injury. So in onset of injury also equally important. Night pain. Shoulder patient has very common complaint, night pain. The reason for the night pain is while sleeping, the cuff is under pressure, so patient is feeling pain. Morning sickness. If the patient has complained of morning sickness for 10 to 15 minutes in the morning, then it's probably the weak rotator cuff and less likely to inflammatory pathology. If the patient has complained of morning sickness more than 1 hour, then it is most probably like inflammatory arthropathy like rheumatoid arthritis. Later sleeping, if patient has complained of sleeping on both sides, not able to sleep both sides, then it is more probably like AC joint arthritis. Inability to throw. Usually younger patients have no complaint of pain, no restriction of movement. They are only complaining they are unable to throw. It does not mean they have any complaint. It is means there is some instability. Medical history. Always ask for medical issues like diabetes and hyperthyroidism. They are always looking for having frozen shoulder and adhesive capsulitis. Wrist pain, it is a severe pathology. While patient is complaining having a severe wrist pain, it may be infection, it may be fracture, or it may be tumor. History of fall. Usually patient came with you after 3 months of injury and they have fall 3 months before and the pain has started after 1 month. So never forget to ask about the history of fall. It may be rotator cuff injury. Also looking for the location of pain, it is patient never complain of the pain at the shoulder joint itself. It is most of the time complaint of the pain is around the shoulder joint, either on your left arm, either on your neck, either at scapular region, or elbow on, and sometimes on fingers and wrist. If the patient has complaint of palms and that is on the lateral aspect of the deltoid, it is maybe the compression of the big cup under acromion and possibility of rotator cuff lesion. Finger sign, it is patient always ask, put your finger around the AC joint. It is usually AC joint arthritis, which is later you can confirm by cross arm test where patient is complaining about the pain at acromial joint. If patient complains during the cross arm stretch, patient complains the pain is on the posterior aspect, it is not AC joint arthritis, it may be something else like posterior capsule tightness or suprascapular neuropathy. The next and medial scapular pain is always dealing with the scapular dyskinesis. Patient has complained at the pain from top to bottom anterior-medially around the bicipital groove. It is probably like elongated bicep impingement. Sometimes patient has come. Usually patient come with you after 3 months and the complaint of pain at elbow, wrist, and the finger. It is not the problem is tennis elbow, but because of the weak curve and the scapular dyskinesis, it's paining at your lateral elbow and the wrist. It's called the proximal instability to distal disability, where the proximal weak muscles can lead to overwork of the distal muscle. There are very common conditions like patient has tennis elbow, wrist pain, even the trigger finger. Those having trigger finger, they have always weak cup and scapular dyskinesis. Because of the weak muscles, they use more the finger flexors. Even patient complain of the different actions of day-to-day life, like powering jug of water is like mimic test of Hawkins sign, suggest of impingement. While your patient coming with your shoulder, the most neglected part is the scapula. We never bother about to look at the scapula, but most of the shoulder conditions and the culprit is the scapula. Whenever patient come to you, always ask them to strip up to the waist level and look at the front and the back of the scapula. What is the normally scapular position? What we are looking in the normal scapular position is anteriorly should check for the acromion, should be at same level on both sides. Clavicle should not be horizontal. In the scapular neutral position, humeral head should not be internally rotated, and olecranon should be faced posteriorly, and cubital fossa always face anteriorly. Posterior aspect of the scapula, you are looking for the no winging of scapula. Medial edge of the scapula, medial border of the scapula always compared with the both sides. Same with medial border edge of the scapula. But usually medial border of the scapula is little bit upwardly rotated. Inferior angle of the scapula is lateral to the root of spine of the scapula. Acromion is higher than the superior border and spine and the scapular angle upward. So what are abnormal you can find in scapula? It's a deformity like kyphosis and scoliosis. In patient with kyphotic and scoliosis, always the glenoid is laterally kyphotic and scoliosis. There is alter in the scapulohumeral rhythm, and the glenoid is laterally rotated. Lateral anterior version process, and it can cause the instability and impingement. Then the scapular winging. There are 3 types of scapular winging. According to Van Kibler, there are 3 types of scapular instability. One is inferior angle of winging. Inferior angle of scapula, winging of the inferior angle of scapula due to the wing, it is a muscular due to the tightness of the pectoralis major muscles and the tightness of the posterior capsules. Medial border of the scapula, it is more probably due to the compression of the long thoracic nerve. This supplies the serratus anterior. superior medial part. This is sorry. The third one is the superior medial angle. That is due to the impingement or neuropathy of the spinal accessory nerve, and which supplies the trapezius and sternocleidomastoid. Then the next part is muscle wasting. If you're looking from the back of the spine, scapula, there is, you can see the wasting of the either supraspinatus, infraspinatus, teres minor, and the deltoid. If there is a deltoid and the teres minor wasting, that is probably of the axillary neuropathy. If there is a wasting of the suprascapular and the supraspinatus and infraspinatus. If you see that there is a supraspinatus wasting at supraspinatus fossa and infraspinatus wasting at infraspinatus fossa. So wasting of the supraspinatus, the isolation wasting of the supraspinatus is due to the supraspinatus lesion only. If it is infraspinatus wasting only, isolation, then possible cause may be the neurocompression of the suprascapular nerve at spine of the scapula, not the rotator cuff lesion. If you find there is a wasting of supraspinatus and the infraspinatus both together, then the possibility of either muscular or neuropathy. Muscular cause may be muscular, that is a rotator cuff lesion, massive rotator cuff tear. And if it is a neuropathy, that is the compression of the suprascapular nerve at the suprascapular notch. How can you differentiate between these two things? There is a Hawkins stage. If Hawkins stage is positive, it means that it is rotator cuff lesion. If it is negative, then it is the neuropathy. And how can you, for suprascapular neuropathy, there is a cross-arm stage and the patient feel pain at the spine of the scapula. So there are some clues finding from the physical examination. It is not giving any of the book, but I have collected this information from some known shoulder surgeons. So if your passive range of movement are more than active, then it is possibility of suprascapular neuropathy or rotator cuff lesion. Painful arc syndrome is from 50 to 120 degrees, then it is the impingement syndrome. Shoulder joint, as we all know, shoulder joint is a ball and socket joint. So if the forward flexion and abduction is reasonably okay, that is the 130 and 140 degree respectively, and the rotations are affected, then your then your shoulder joint stops behaving like a ball and socket joint and it acts like a hinge joint, and the condition you can deal with adhesive capsulitis, osteoarthritis, or dislocation where the ball and socket joint is not contact with anymore. If you see the upside down, then rotations are okay and the forward flexion and abductions are significantly affected, then the condition is suprascapular neuropathy or axillary nerve neuropathy or severe impingement, or you can see the big spur under the subacromial stage. There are some indicators which gives us some idea whether the shoulder pain is coming from shoulder joint itself or it is referred from spine, that is cervical or thoracic. So if you're looking for in the history and examination, if patient has presence of paresthesia, effect on symptoms with seating means effect of symptoms are increase or reduce with neck movement, then it is also related. Pain is referred from spine. Postural change also affect the symptom. If your correction of posture reduce the shoulder symptoms, it is always related to your neck problem. Perceived restriction of spinal movement. If your neck movements are restricted and the pain is in shoulder, so obvious assess first neck before shoulder. And if the shoulder movements are extremely free without any pain, then always most probable possibility that shoulder pain is coming from cervical. Thank you.
Hello. Excellent, Amit bhai. Few questions from orthopedic perspective. So, since last 3 years post-COVID, we have seen in our OPD large number of patients coming, young patients, coming with a diffused neck, back of the shoulder and the arm pain. And in the history, as you rightly mentioned, if you ask for the profession or if you ask for the specifically screen time, many of them habit of seeing mobile like this, or the kids reading books, or in the office they are sitting in a desk for a long time. So can you throw some light that what is the ideal position for the screen or while sitting to avoid the severe tightness of the neck shoulder muscles, and because of that tightness, and when they go for sports they'll end up in injury. Even we have seen tennis elbow coming because of the tightness of the shoulder muscles. So if you can demonstrate the proper posture and how to assess that if the patient is having the proper position or not.
First of the patient is coming with your forward neck posture.
No, the
In this
forward neck posture diagnosed by us, but they are coming with the neck and the shoulder pain. But if you take the proper history, nowadays there is a work from home. People sit for a long time in front of the screen. People are getting addicted to web series, looking at the phone for a long time. So, yeah, you can have. So what I'm asking that if you do X-ray, MRI, everything will be normal. But just with the history, you can diagnose the majority of the shoulder problem. Very. So 70 to 80% of our OPD of the shoulder pain, we have seen majority are having issue because of the bad posture. So that is a very important topic that you can just diagnose through the history.
Whenever you are dealing with your neck pain or anything, first you have to ask the patient to correct their posture. It's not only from the neck, also you have to correct from the lower back also. So always ask the patient to take your buttocks as much as possible. Then keep the this not this one, but keep the soft pad. Just support the lower back, that is your lower back only, not the whole back. So if you give your support like this, then it's a correction of the posture. And ask them to keep your neck straight. And always ask them to keep the screen at the eye level, not the below, not down, and then looking up. If you see if patient is if patient is on the laptop or desktop, see the posture. See, he is also bending from the back, and also the shoulders are rounded and the head is forward. If you correct this posture, then automatically your shoulder is on parallel each other and the head is also in the neutral position. So once you correct this one lower back, automatically you can correct this. And as you ask the leg tennis elbow, sorry, tennis elbow patient with from the shoulder. Most of the patient with tennis elbow having the because of the big rotator cuff and scapular dyskinesia. So if you correct if you strengthen the scapular stiff muscle and the big cuff, especially infraspinatus, then it pains.
Thank you. Anubi, I would request Dr. Pampi to present a moment or two Amit Bhai for a wonderful lecture and sparing his precious time on this Sunday morning. So from orthopedic perspective, from the history, just by asking few questions you can thank you, Amit Bhai. Next I would invite any of Dr. Punam is asking a few questions, but any of you have questions, feel free to ask.
Good morning, sir. Sir, I have one question. Should we educate that person for the height of chair and pieces on the screen and for everything?
It's not
on the height of the chair, it's also the desktop level. Because while you are dealing with ergonomics, you are not the only chair, you are dealing with the table, laptop, and keyboard. Ideally, what people are using laptop. So the keyboard is always up to at the shoulder level or above the elbow level. I always ask my patient to use if they are on the laptop, ask them to use keyboard, that's called portable keyboard, keypad. So they keep on like a keyboard at your elbow 90 or below 90. So it would less pressure on your shoulder. So not only that, also ask the patient to keep everything under your level, that is keep this degree, not outstretched or bend like this. And there are many professions, they are using two screens. One is the laptop, one is the desktop. So ask them to use the both screen in front of them, in front of their face, not the sideways.
Just to add a few more things for history. If you ask detailed questions you can make out many diagnoses. For an example, patient coming with the shoulder pain and the age is somewhere between 45 to 60. Then you are sure that it is something not related to shoulder dislocations or liberal pathology like SLAC or glenohumeral interrotation deficit. But at 45 to 60, you are looking at either rotator cuff tear, subacromial impingement, adhesive capsulitis, or acinar arthritis. So from the age, you can make all these 4 things. Next would be just if the patient is female and housewife, you can ask કે તમે રસોડામાંથી ઉપરથી વસ્તુ લેવામાં કોઈ તકલીફ પડે છે કે પાછળ બટન બંધ કરવામાં તકલીફ પડે છે તો patient will say કે હાથ પાછળ નથી જતો. Or male patient to take pocket purse from the pocket would be very difficult, or the combing hair will be difficult, or they will say that I'll comb hair like this, the trick movements. Second thing is the night pain. So as Amit Bhai rightly said, the subacromial pathologies have significant night pain because at night rotator cuff comes under tremendous pressure. So night pain is very very important. Without touching the patient, you can make out pain kya hai. So if patient is showing pain with the palm like this in the deltoid insertion area, then mostly it is related to the impingement or adhesive capsulitis or cuff. But they are showing with the finger, then you can see that there is bicep tendinitis or acinar arthritis. So history is very important. So next I will invite Dr. Ronak Patel for the examination. So examination is an extremely important part of diagnosing any shoulder condition. So as we divide into 3 parts, part A, B and C. Part A is the history taking, part B is examination, and part C is imaging. In examination we can broadly divide into 3 parts: look, feel and move. So first you look at the patient, you see the general condition, then you come to the feel, that means you touch, you do the special test, and third you do move and check specific condition. Before we begin, I would ask Partho bhai, what protocol do you follow in your clinic if any patient comes to you with shoulder pain, and how do you proceed, approach, what is your protocol?
Assessment, are you talking about assessment? Right?
History taking, diagnosis, examination. So what is your protocol?
So I'll usually use the SOAP notes as a subjective assessment, then objective, then analysis and then planning. મને થોડું વધારે ફોર્મલ લાગી રહ્યું અહીંયા સિચ્યુએશન. આઈ ફીલ કે વધારે ઇન્ટરેક્ટિવ હોવું જોઈએ. તમારા બી ઓપિનિયન્સ મેટર કરે, જેમ સર્ટેન ઓપિનિયન અમિતભાઈના ને એવા હતા, તો વધારે વાત કરીશું તો વધારે સારું રહેશે રાધર દેન જસ્ટ સિટિંગ. સો આઈ જસ્ટ આસ્ક યુ, જનરલી અસેસમેન્ટ અમે લોકો સ્ટાર્ટ કરતા હોઈએ હિસ્ટ્રી ટેકિંગ, જે અમિતભાઈએ કીધું કે હિસ્ટ્રી લેવી બહુ જ જરૂરી, બિકોઝ તમે ફર્સ્ટ ટાઈમ મળી રહ્યા છો પેશન્ટને, યુ નેવર નો શું છે શું નથી એ બધી વસ્તુ. સો એઝ એન સ્પોર્ટ્સ injuries prospect, I'll make sure કે history taking માં workload વધારે important હોય. So એમના કેસમાં વધારે maybe he might be dealing with more recreational players and બીજા general population. So I deal with the workload. So ખાલી એક વસ્તુ એડ કરવા માંગીશ હું, workload અમે લોકો વધારે લેતા હોઈએ કે sports person માં, as he already mentioned that dominancy important છે shoulder injuries માં, કે dominant કયો છે કે કયો નથી. તો એના સિવાય હું એટલે લાઈક અ સ્પોર્ટ્સ પર્સનની જ વાત કરું તો સ્પોર્ટ્સ ઇન્જરીઝમાં પ્લેયર્સ બહુ બધી વસ્તુઓ કરતો હશે રમવા સિવાયનું. તો ફોર એક્ઝામ્પલ ઓવરહેડ સ્પોર્ટ્સ છે કે નથી એ બી મેટર કરે. ઓવરહેડ સ્પોર્ટ્સ સિવાય વેઇટ ટ્રેનિંગ કરતો હશે, કન્ડિશનિંગ કરતો હશે, એ બી એક વન ઓફ ધ અગ્રીવેટિંગ ફેક્ટર હશે કે કોઝેટિવ ફેક્ટર હશે એમાંનું. સો આપણે ટ્રાય કરીશું એ બી આઈડેન્ટિફાઈ કરવાનું કે આપણને ખબર પડે. સો વર્કલોડ આઈ મેક ઇટ સિમ્પલ, નોટ કોમ્પ્લિકેટેડ કે વધારે ખબર ના પડે કે બહુ કન્ફ્યુઝિંગ થાય એવું નહીં. So I'll ask them કે તમે કઈ ટાઈપની ટ્રેનિંગ કરો છો સ્કિલ સિવાય. સો ફિઝિકલ વર્કલોડ આપણે જાણવાનો ટ્રાય કરીએ છીએ કે ફિઝિકલ વર્કલોડમાં તમે સ્ટ્રેન્થ ટ્રેનિંગ કરો છો કે નથી કરતા, સ્ટ્રેન્થ ટ્રેનિંગ વેઇટ ટ્રેનિંગ કરો છો તો વેઇટ ટ્રેનિંગ કઈ ટાઈપની કરો, આઈધર આઇસોલેટેડ, આઈધર કોમ્પ્લેક્સ ઓર આઈધર ફંક્શનલ, આ 3 ડિફરન્ટ યુઝ્યુઅલી વેઇટ ટ્રેનિંગ થતી હોય. એ સિવાય એમનો જે સ્કિલનો વર્કલોડ છે એ બહુ મેટર કરે કે ફોર એક્ઝામ્પલ ક્રિકેટરને પૂછવામાં આવે કે તમે કેટલી પ્રેક્ટિસ કરો, કેટલા આર્સ પ્રેક્ટિસ કરો, કેટલી ઇન્ટેન્સિટીથી પ્રેક્ટિસ કરો તમે. સો મોસ્ટ ઓફ ઇન્જરીઝ જે શોલ્ડર ઇન્જરીઝ હોય એમાં વધારે મેટર કરે ઇન્ટેન્સિટી રાધર દેન ધ ફ્રીક્વન્સી અને ડ્યુરેશન. સો આપણે ટ્રાય કરીએ કે કેટલી ઇન્ટેન્સિટીથી તમે પ્રેક્ટિસ કરો અને કેટલા થ્રો કરો, વીકલી કેટલા થ્રો કરો. સો આપણે ટ્રાય કરીએ લાસ્ટ 4 વીકનું ગેધર કરવાનું, લાસ્ટ 4 વીકમાં તમે કેટલા થ્રો કર્યા હતા, કેટલા. સો એમાં કોઈ ચેન્જીસ છે કે તમે નતા કરતા અને હવે કરો છો, તો એ સબ્જેક્ટિવ એસેસમેન્ટમાં તમે વર્કલોડ બી એક એડ કરી શકો. બીજી વસ્તુ ખાલી જસ્ટ આઈ એમ એડિંગ વિથ વન પોસ્ચર્સ. We don't bother about much static postures. We'll look for the dynamic posture most of. કારણ કે આપણી જોડે એવિડન્સ નથી કે કોઈ સ્ટેટિક પોસ્ચર્સ આપણે ચેન્જ કરી શકીએ. અગેન ફોર મી ઇટ ઇઝ જે રોહનભાઈનો ક્વેશ્ચન હતો એનો એક ખાલી મારો વ્યૂઝ છે. એવું નથી કહેતો કે આ જ વસ્તુ હોઈ શકે, બટ મારો વ્યૂ છે કે આઈ ડોન્ટ પ્રિફર મચ એર્ગોનોમિકલ બીકોઝ સેટિંગ ઇઝ ઓનલી પોસ્ચર્સ, રોંગ પોસ્ચર્સ. તો આપણે જો એમને કમ્ફર્ટેબલ કરી દઈશું તો એ વધારે બેસ્ટ છે. તો હવે સિટિંગ જ પ્રોબ્લેમ છે. અગેન એઝ હી સેડ કે રિસેન્ટલી બહુ જ વર્કલોડ ચેન્જ થયો છે એટલા માટે એને પેઇન થાય છે. અને જ્યારે ફોરવર્ડેડ પોસ્ચર છે તો બે વસ્તુ એમાં ધ્યાન રાખવાની, ચેન્જ કરવાની જરૂર છે, બટ આઈ ટ્રાય ટુ આઈડેન્ટિફાય ઇઝ ઇટ પ્રોટેક્ટિવ પોસ્ચર્સ ઓર નોટ ફર્સ્ટ. ઇફ ઇટ ઇઝ પ્રોટેક્ટિવ પોસ્ચર નો નીડ ટુ ચેન્જ, કારણ કે પ્રોટેક્ટ કરી રહ્યું છે બોડી. સો પેઇન ઇઝ ગિવિંગ ધ ફીડબેક કે સમથિંગ ઇઝ રોંગ, યુ રિયલી નીડ ટુ વર્ક ઓન ધેટ પાર્ટ. સો હું બહુ ક્લિનિશિયન વેઝ વાત કરીશ, નોટ લાઈક એકેડમિશિયન વેઝ. સો આઈ પ્રિફર્ડ કે જો એ પ્રોટેક્ટિવ પોસ્ચર્સ હોય તો આઈ ડોન્ટ ચેન્જ, કારણ કે એ હેલ્પ કરી રહ્યું છે આપણને. સો ઇન્ફ્લેમેશન જે બોડીનો નોર્મલ પ્રોસેસ છે તો એને હું ચેન્જ કરીશ તો ઉપરથી વધારે એગ્રીવેટ કરી દઈશ હું કન્ડિશન. ઇફ ઇટ ઇઝ નોટ પ્રોટેક્ટિવ, ઇફ ઇટ ઇઝ ક્રોનિક, ધેન વિલ ટ્રાય ટુ વર્ક ઓન ધેટ. અને મારું સજેશન એવું હોય છે કે આઈ મેક શ્યોર કે એમને એવું સજેશન આપું કે એવરી 20 મિનિટ્સ હી ગેટ અપ. સો વન્સ હી ગેટ અપ ઓટોમેટિકલી સ્ટ્રેચ થઈ જાય રાધર દેન ગિવિંગ એનીથિંગ. સો એના પાછળના રીઝનિંગ તમે આપી શકો, એજ્યુકેટ કરી શકો કેમ તમને હું આ સજેશન આપું છું. એક સજેશનથી બહુ બધા બેનિફિટ થઈ શકે કે વેન યુ સ્ટેન્ડ અપ ઓટોમેટિકલી તમારી રીપ કેજ ઓપન થાય છે, તમારા હાર્ટ વર્ક કરવાનું સ્ટાર્ટ થાય, લંગ્સ ઓપન અપ થઈ જાય છે, પ્રોપ્રોસેપ્શન્સ બેટર થઈ જાય છે, મસલ્સ બેટર થઈ જાય, નેક. સો એનાથી બહુ બધા બેનિફિટ થઈ શકે. એટલે ઇફ યુ લુક એટ ધ પ્રોસ્પેક્ટ ઓફ ધ પેશન્ટ્સ, બહુ બધી વસ્તુઓ તમે સજેશન આપશો તો નહીં કરી શકે. સો લુક ફોર ધ સિમ્પલ સજેશન કે કઈ રીતના આપણે એને બેટર કરી શકીએ, રાઈટ? સો સર્ટેન કન્સ્ટ્રેન્ટ હશે, જે અમિતભાઈએ કીધું એ સર્ટેન કન્સ્ટ્રેન્ટમાં વર્ક કરશે 100%. જે એમને કીધું, હું ડિનાય નથી કરતો કે નહીં વર્ક કરે, પણ સર્ટેન જગ્યા એવું હશે કે કન્સ્ટ્રેન્ટ કે ઓફિસ વર્ક છે કે એ લોકો ચેન્જ કરવા માટે ડેસ્ક નથી રેડી, કે લેપટોપ કે હાઇટ કે એમના માટે કોસ્ટિંગ ઇફેક્ટ છે કંપનીની, અને એને જોબ કરવી જરૂરી જ છે. એ પર્સન જોબ જો છોડી દે તો મેન્ટલી સ્ટ્રેસમાં આવી જશે. તો સમથિંગ યુ કેન લુક ફોર ધીસ ઓપ્શન્સ ઓલ્સો કે આવી રીતના તમે એમને સજેસ્ટ કરી શકો, રાઈટ? Thank you. Thank you.
Namaste. Shoulder examination. For examination, a part of assessment where we always want to jump first or as soon as possible, and આપણે લોકો ક્વિક ડાયગ્નોસિસ કરી નાખીએ અને પેશન્ટને ટ્રીટમેન્ટ આપી દઈએ. I made this PPT from reference material, but along with this PPT, I'll also share my personal clinical experience. કોઈ જગ્યાએ ફોટો તો પ્લીઝ કરેક્ટ કરજો. Physical examination must be thorough and systematic. હવે કોલેજમાં જે આપણે ભણે સિસ્ટમેટિક ડઝન્ટ મીન કે આપણે લોકોએ સ્ટાર્ટિંગ ફ્રોમ રૂટેડ ઓફ ટેરથી શરૂ કરી લેબ્રમ, એસી જોઈન્ટ બધાના ટેસ્ટ દરેક પેશન્ટ ઉપર કરવા જરૂરી છે. ઇટ્સ નોટ લાઈક ધેટ. Systematic in regard to sequence, not every special case to include. Subjective examination, just હમણાં જ કર્યું. For example, કે કોઈ બી assessment if we cover અથવા examination, patient તમે consult કરતા હશો આટલા બધા લોકો, ideal time એવું કંઈ ના હોય, પણ કેટલો લાગે એમ રફલી એક એક્ઝામિનેશન એક પેશન્ટનું કરતા રફલી કેટલો ટાઈમ લાગવો જોઈએ અથવા કેટલો ટાઈમ લાગે? It depends on experience, yes. 10 મિનિટ કોઈના માટે અડધો કલાક. હું તમને કહું મારા માટે 45 મિનિટ તો મિનિમમ થાય છે મારે તો રોજ ક્લિનિકમાં. આઈડિયલ ટાઈમ કેવું બી હોય
ઓપીડીમાં કેટલું વેઇટિંગ છે એની બધી.
પછી બીજું કંઈ બીજી રીતે ફોર એક્ઝામ્પલ કે ઓપીડીમાં પેશન્ટ વેઇટિંગ નથી કરતા અને આઈડિયલી તમે પેશન્ટને 10 વાગ્યાનો સમય આપ્યો છે અને 10 વાગે તમારે ત્યાં પેશન્ટ આવી ગયું, કેટલો સમય લાગવો જોઈએ?
It also depends on if the diagnosis is just in the history, as Amit bhai said. કે ઘણી બધી વખત હિસ્ટ્રીમાં જ ખબર પડી જાય શું પ્રોબ્લેમ છે, then the total duration will cut short.
યસ. બીજો કોઈ આન્સર?
કન્ટેસ્ટ ઓફ પેશન્ટ્સ ને શું છે શું નથી.
યસ. સમટાઈમ્સ ડિપેન્ડ્સ ઓન પેશન્ટ્સ. પેશન્ટ આપણને 2023માં બતાવવા માટે આવ્યો આપણને 2000 હિસ્ટ્રી સ્ટાર્ટ કરે તો વધારે સમય લાગે. મોસ્ટ ઇમ્પોર્ટન્ટ પાર્ટ ઇઝ સબ્જેક્ટિવ અને ઓબ્જેક્ટિવ. તમે જો ડિવાઈડ કરો તો મારું એવું માનવું છે કે સબ્જેક્ટિવ અસેસમેન્ટ ઇઝ according to me, not from any reference or articles, subjective assessment 60% સમય લાગવો જોઈએ અને ઓબ્જેક્ટિવને 40%. 60-70 હું સબ્જેક્ટિવને કહીશ. ઓબ્જેક્ટિવ ઇઝ 30%. Listening to the person is often most helpful part of examination. Let them talk, but lead them as needed. હું મારા ક્લિનિકમાં એવું કરું છું, પેશન્ટ આપણે ત્યાં આવ્યો તો સ્ટાર્ટિંગ ફ્રોમ શું થયું હતું, કેવી રીતના પેઇન સ્ટાર્ટ થયું, તમે જેમ ક્વેશ્ચન પૂછે રીતના પૂછું છું. સો અને ઇફ દે આર ગોઈંગ ઇન ધ રોંગ ટ્રેક તો હું પાછો આવી કે ભાઈ પેલું મારે જરૂર નથી ની પેઇન વાળું, આપણે અત્યારે શોલ્ડર માટે છે તો શોલ્ડરનું મને વાત કરું અને આસ્ક ધેમ પ્રોપર ક્વેશ્ચન્સ. બેઝિકલી શું થયું તો જેમ ચીફ કમ્પ્લેન તમે લેતા હોવ છો કે આઈડિયલી કઈ મુવમેન્ટ વધારે પેઇનફુલ છે, સરે કીધું એ પ્રમાણે નાઇટ પેઇન થાય છે કે નહીં. હું અમુક ક્વેશ્ચન્સ સ્ટ્રિક્ટલી દરેક પેશન્ટને પૂછું છું. વેધર ઇટ ઇઝ મને ખબર હોય કે પેશન્ટ હિસ્ટ્રી આપી છે એન્કલ સ્પ્રેનની તો બી ફોર એક્ઝામ્પલ કે નાઇટ પેઇન, મોર્નિંગ સ્ટીફનેસ, વેધર તમે જ્યારે સવારે ઉઠો છો તો મોર્નિંગ સ્ટીફનેસ વધારે બોધર કરે છે કે પેઇન વધારે બોધર કરે છે. સ્ટીફનેસ હશે તો કેટલા સમયમાં ઓછી થઈ જાય છે, like they just take a few steps and their stiffness is fine, or it is taking like more than 30 minutes or 2 hours of time to reduce the stiffness, or it is whole day, the same scenario, continuous pain થાય છે. Second question is about medical history. Mostly અત્યારે આપણે જે લાઈફસ્ટાઈલ છે પ્રમાણે ડાયાબિટીસ, હાઇપરટેન્શન, થાઇરોઇડ એ બધું જ કોમન હોય છે. તો સ્પેસિફિકલી તમે આ 3 કન્ડિશન ના આપી શકો છો અને પછી પૂછી શકો છો કે બીજું કઈ વસ્તુ કરે કે જે ધ્યાન આપવાનું હોય. રૂટીનમાં કોઈ પર્ટિક્યુલર મેડિસિન્સ તમે લઈ રહ્યા છો કે જે, તો કે હા મેડિસિન લઈ રહ્યા છો તો આપણને આઈડિયા આવશે કે આ મેડિસિન આના કારણે છે. સમટાઈમ્સ આપણે કેન્સરના પેશન્ટ બી જોતા હોઈએ છીએ તો હિસ્ટ્રી હોવી જરૂરી છે. ફિમેલમાં બ્રેસ્ટ કેન્સર્સ આપણે જોતા હોઈએ છીએ. The next one is about habits. Our habit includes everything. For example, કે morning walk કરતા knee pain થતું હોય, they do some exercise by themselves at home and they have a pain. કોઈ પર્ટિક્યુલર સ્પોર્ટ્સ રમતા હોય, સાયકલિંગ કરતા હોય છે, ઘણા લોકો આઈટી રિલેટેડ વર્ક કરતા હોય છે. હમણાં મારે પેશન્ટ નેક પેન સાથે આવેલો, સરે વાત કરીએ પ્રમાણે સ્ક્રીન ટાઈમ ને બધા પ્રમાણે, અને વાતમાંથી વાત નીકળી એસેસમેન્ટ માટે જ સ્ક્રીનિંગમાં જ આઈડિયલી નેટફ્લિક્સ એટલે ટીવી સિરીઝ એ બધાને એમને બહુ શોખ હતો. તો ઓલમોસ્ટ એવરી ડે સાંજે વર્ક કર્યા પછી એ ઘરે જાય અને દેન ઈ સ્ટાર્ટ ટીવી શોઝ ઓર મૂવીઝ અને રાત્રે 1-2 કેટલા વાગશે ખબર નથી પણ એવરી ડે હેબિટ એમની એ જ હતી. અને દેન ધી હેઝ અ નેક પેઇન. પછી તમે ટ્રીટમેન્ટ આપે પણ ઇટ ઇઝ અવર રિસ્પોન્સિબિલિટી ટુ પ્રોવાઈડ એન એડવાઇસ. સરે કીધું એ પ્રમાણે એર્ગોનોમિકલી આપણે કંઈ જોવા જવા નથી ઘરે કે કઈ રીતના બેઠા છે. ઇવન ઇટ ઇઝ નોટ પોસિબલ ફોર અસ ઓલ્સો ટુ સિટ ઇન આઈડિયલ પોઝિશન ફોર લોંગર પીરિયડ ઓફ ટાઈમ. આપણે જ્યારે મૂવી જોતા હોઈએ તો આપણે પોઝિશન ધ્યાન નથી રાખતા કે થિયેટરમાં ગયા તો તમે ઉપર રાખો, એલ્બો સપોર્ટેડ રાખો, નેક સીધું રાખો, ના, ઇટ ઇઝ રિલેક્સ પોઝિશન. બરાબર, પણ હા રિલેક્સ પોઝિશન જો બોધર કરતું હોય તો આપણે જાણવું બહુ જરૂરી છે. સબ્જેક્ટિવ એક્ઝામિનેશન વિલ લીડ ટુ ઓબ્જેક્ટિવ એક્ઝામિનેશન. ક્વેશ્ચન્સ ઉપર તમને આઈડિયા આવશે કે કઈ કન્ડિશન્સ હોઈ શકે છે અથવા તો કયું એક્ઝામિનેશન પહેલા કરવું જોઈએ. Objective. The objective portion follows a systematic approach. The subjective examinations leads from where to begin the examination or what to look for. A basic principle છે. કદાચ મારી સાથે 9-10 પોઈન્ટ હશે, તમારા કદાચ 15 બી હોઈ શકે અને કોઈના કદાચ 3 બી હોઈ શકે. મને આદત નથી જગ્યા ઉભા રહેવાની એટલા માટે. Basic principles. Test on inward side first for the comparison. So if somebody is having a right shoulder pain and before you ask them to perform active movement, please ask them to perform the same movement, whether it is flexion, abduction or whatever you want to examine, actively or passively first perform on the uninvolved side. It will give you the idea whether the patient has a pain in this range over the right side, he doesn't have a pain over the left side. So always this is must. Test uninvolved side first. Second, does this make it better, worse or the same? There are many of patients કે જેમને severe shoulder pain હશે and if you perform some tests or palpations એ બધા તમારા પોઝિટિવ હશે. But which are the familiar one? Which are the familiar one કે જેને same symptoms produce કરે જેનાથી હેરાન થતા હતા? So try to find that. Which movement even during your examination abduction માં pain વધી ગયું તો try to note it down. અને તમે રિહેબમાં એ એક્સરસાઇઝ અવોઇડ કરશો. ઓકે, સો એક્ઝામિનેશન ઇઝ નોટ અબાઉટ જસ્ટ ફાઇન્ડિંગ સમથિંગ ઓર ડાયગ્નોસિસ સમથિંગ. એઝ અ ફિઝિયોથેરાપિસ્ટ ઇઝ વેરી ઇમ્પોર્ટન્ટ. એક્ઝામિનેશન એ આપણું એક રિહેબ પ્લાન કરવામાં બહુ હેલ્પ કરશે. Is that your symptoms or is that familiar with the movements? Use the pain scale to document. I used to work with a tennis player in academy. અને મેં ત્યાં બધા છોકરાઓ નાનાથી શરૂ કરીને મોટા લોકોને 0 to 10 આપણે જે યુઝ ફોલો કરતા હોઈએ છીએ એ બધાને પેઇન સ્કોર શીખવાડેલો. સો વેન એવર દે આર કમિંગ ટુ માય ઓપીડી તો શોલ્ડર પેઇન થાય છે તો પછી કેટલો પેઇન સ્કોર છે કરાવો. એન્ડ આઈડિયલી કદાચ કોઈ સામે નાનો છોકરો તો કદાચ ખોટું બી બોલતા હોય પણ આપણને આઈડિયા આવી જશે કે વોટ હી ઇઝ ફિલિંગ વિથ ધ પેઇન અને આપણે એક્ઝામિનેશન પર આઈડિયા આવશે કે વેધર પેઇન ઇઝ માઇલ્ડ મોડરેટ ઓર સિવિયર કેટેગરી. તો ઇફ ધ પેઇન સ્કોર ઇઝ અરાઉન્ડ 5 or 6 અને જો મેચ રમતો તું ના પાડીશ કે મેચ રમીશ નહીં બીકોઝ એટ ધ એન્ડ 5 or 6 પેઇન સ્કોર સાથે તમે યુ આર ગોઈંગ ટુ પરફોર્મ યોર 100%. હવે આપણે કોઈને બતાવવા માટે મેચ નથી રમતા. ઇટ ઇઝ અબાઉટ અવર સેલ્ફ. તો એક્સેપ્ટ હું ના પાડી દઈશ કે 5 થી 6 પેઇન સ્કોર હોય તો મેચ કન્સિડર નાખો અથવા ઇવન પ્રેક્ટિસ કરતો તો કન્સિડર નાખો. ઇફ ઇટ ઇઝ અરાઉન્ડ 2 or 3 આપણી પાસે થોડું સ્પોર્ટ્સ વિશે થોડો એક્સપિરિયન્સ હોય થોડો સમય હોય ટ્રીટ ધેમ અપ્લાય સમ કાઇનેશિયોથેરાપી એન્ડ વી કેન સેન્ડ ધેમ લાઈક એઝ સૂન એઝ પોસિબલ. સો પ્લીઝ યુઝ પેઇન સ્કેલ. આપણે ભણીએ છીએ પણ યુઝ નથી કરતા. ઇવન ડ્યુરિંગ યોર અવર રિહેબિલિટેશન અઠવાડિયા પહેલા પેઇન સ્કોર 5 હતો, આજે પેઇન સ્કોર 7 છે. ઇટ ઇઝ નોટ અ ગુડ સાઇન. બટ ઇફ પેઇન સ્કોર ઇઝ 2 or 3 ઇટ ઇઝ ઇમ્પ્રુવિંગ. ઇવન તમે અસેસમેન્ટ નથી કર્યું પણ ફરી સ્વેલિંગ હશે પણ એને કીધું મારું પેઇન સ્કોર પહેલા 5 હતો આજે 2-3 છે તો હી ઇઝ ઇમ્પ્રુવિંગ. ઇટ ઇઝ અ ગુડ સાઇન. અને એ પ્રમાણે ઇવન પેશન્ટ્સના માઇન્ડમાં બી વસ્તુ અનકોન્શિયસલી સ્ટોર થઈ કે આઈ એમ ઇમ્પ્રુવિંગ. એક્ટિવ રેન્જ ઓફ મોશન બિફોર પેસિવ રેન્જ ઓફ મોશન. હંમેશા જેમ સર કીધું પ્રમાણે પેશન્ટને શાંતિથી સાંભળો. ટ્રાય ટુ પરફોર્મ સમ એક્ટિવ રેન્જ ઓફ મોશન એટલે ખાલી ગાઈડ કરો એમની સામે ઉભા રહો અને પર્ટિક્યુલર એઝ અ ફિઝિયોથેરાપિસ્ટ આપણે એમને બતાવવું છે કે આ શોલ્ડર તો એલ્બો સીધો રાખજો અને ખાલી હાથ ઉપર કરવાનો પ્રયત્ન કરો. ઇટ ઇઝ નોટ નેસેસરી કે આપણે એમને બતાવીએ કે અંગૂઠો ઉપર રાખજો આમ રાખજો પછી આ રીતે ઉપર કરજો. નો સિમ્પલ મૂવમેન્ટ્સ કે ટ્રાય ટુ એક્ટિવેટ ઓર ટ્રાય ટુ રેઝ યોર હેન્ડ અપ ઇન ધીસ મોશન. સાઇડવેઝ ઉપર કરો, સાઇડવેઝમાં આ મૂવમેન્ટ કરી જુઓ. પેન ઓછું હોય તો દેન ફ્રોમ હિયર ટુ રોટેટ એન્ડ ટેક ઇટ ફ્રન્ટ. સો એક્ટિવ રેન્જ ઓફ મોશન બિફોર ધ પેસિવ રેન્જ ઓફ મોશન ઘણા બધા કેસીસમાં તમને કામમાં આવશે અને આઈ શો યુ ઓલ્સો. So for example, patients with frozen shoulder or adhesive capsulitis will not be able to perform the active movement completely. કોઈને કદાચ 90 ડિગ્રી હશે, કોઈને 120 ડિગ્રી હશે, પણ કમ્પ્લીટ નહીં. ઇવન એક્ટિવ મૂવમેન્ટ વખતે યુ વિલ ફાઇન્ડ સમ કાઇન્ડ ઓફ ટ્રીક મૂવમેન્ટ પોસ્ટ ઓપરેટિવ પેશન્ટ્સની અંદર. સો અને પેસિવ મૂવમેન્ટ તમે પરફોર્મ કરીને એમાં બી તમને રેસ્ટ્રિક્શન જોવા મળ્યું દેન ઇટ ઇઝ અ સાઇન ઓફ સ્ટીફનેસ. પણ તમે એક્ટિવ પરફોર્મ કરી જે પૂરી ન હતી અને પેસિવ પરફોર્મ કરી એ પૂરી હતી દેટ ઇઝ અનધર કન્ડિશન. Quantity and quality. So most important, it's a part of observation. Okay, how patient is performing the movement. Is performing with some kind of trick movement. It can be any trick movement from neck, back. અત્યારે જેમ સોરી કીધું પ્રમાણે ideally because of after COVID, TV shows or mobile uses વધી ગયા છે એના કારણે even posture બી ખરાબ થઈ ગયા છે. It is affecting even our shoulders, indirect way or direct way. So for example, somebody has a static posture. Sorry, કીધું પ્રમાણે સાચી વસ્તુ છે કે ઘણા બધા આર્ટિકલ્સ વાંચો તો સ્ટેટિક પોસ્ચર ઇઝ નોટ એટ ઇમ્પોર્ટન્ટ રાઇટ નાઉ. ઘણા બધા એથ્લેટ્સમાં તમે જોવા મળશે if somebody is playing a tennis you can easily mark they have this kind of posture but it is helping them during their match or during their practice. So it is not wrong for them, it is wrong for our observation. કેમ કે આપણે પ્રમાણે ભણ્યા છે કે ના પોસ્ચર આ પ્રમાણે હોવું જોઈએ. એન્ટ્રીઓ પેલ્વિક ટિલ્ટ આપણે બધા જ કરેક્ટ કરીએ છીએ પણ મોર દેન 60 or 70% ઓર ઘણા બધા પોપ્યુલેશનને એન્ટ્રી પેલ્વિક ટિલ્ટ હશે જ. So it is not a wrong posture. Okay, so quantity versus quality. Try to observe the movement, try to observe the posture, how they are performing the movement. So somebody is suffering with thoracic kyphosis એમને ખબર નથી પણ they have hump back. બરાબર, thoracic માં kyphosis હોવો જ જોઈએ, ના નથી પડતું પણ if you are observing them ના આવું તમે કદી જોયું નથી અથવા તો આ થોડું મને વધારે લાગી રહ્યું છે then you are completely right. હોઈ શકે કોઈને વધારે kyphosis and with the kyphosis they are performing the movement તો કદાચ full flexion નહીં આવે કદી. બરાબર. So it is not about shoulder right now, it is about thoracic spine. So always try to look for the quantity and quality. Mobility before મોટા કંટ્રોલ. સો ઓલવેઝ જેમ આપણે એક્ટિવ મૂવમેન્ટ કરતા હોઈએ છીએ તો ફોરવર્ડ ફ્લેક્શન, સ્કેપ્શન, અબડક્શન, એક્શન રોટેશન, ઇન્ટર રોટેશન એ બધું ચેક કરો. Then try to perform with some motor control or some kind of special test or resistance test. Painful movements, provocative tests, and palpations performed towards the end. Always patiently થોડા distance maintain કરો, એટલે touch ના કરો જો unnecessary કે મને pain થાય છે. બધું જ દબાઈ ના લો shoulder surrounding area, and the pain વધશે. અને after that you are performing active movement, passive movement or any kind of special test, everything is positive. But everything is false positive. Okay, so whatever you are finding કે palpations હું એવું એડવાઇસ કરું છું કે લાસ્ટમાં રાખો. બધું જ પતી જાય તમારા સ્પેશિયલ ટેસ્ટ પતી જાય પછી જ પાલ્પેશન્સ કરજો. ઇટ વિલ નોટ પ્રોવોક ધ પેઇન અને તમારું રિઝલ્ટ થોડું નિયર ટુ એક્યુરેસ આવશે. અસેસ એન્ડ રીઅસેસ ફ્રીક્વન્ટલી એ આપણને ફર્સ્ટ યર સેકન્ડ યરમાં જેવું આપણું ઓર્થો સ્ટાર્ટ થાય થર્ડ યરમાં તરત આપણને કહેવામાં આવતું હોય છે. સો મારા ત્યાં એવું રાખ્યું છે આઈડિયલી મારા ક્લિનિકમાં અમે 8 થી 10 દિવસે પેશન્ટનું રીઅસેસમેન્ટ કમ્પલસરી કરતા હોઈએ છીએ. હવે રીઅસેસમેન્ટ મતલબ એવું નહીં કે તમે જે કન્સલ્ટિંગમાં 45 મિનિટ આપ્યો તો ફરીથી કન્સલ્ટિંગમાં 45 મિનિટ આપો, એવું નથી. ઇટ ઇઝ અબાઉટ કન્સલ્ટિંગ વખત તમે જે પોઈન્ટ નોટ કર્યા હતા 5, 7, 10 જે ફાઇન્ડિંગ્સ હતા, ટેન્ડરનેસ, સ્પેશિયાલિટીઝ આટલા પોઝિટિવ હતા, એક્ટિવ રેન્જ ઓફ મોશન આ પેઇનફુલ હતી, જે પોઝિટિવ પોઈન્ટ હતા એ જ તમારે ફરીથી રીઅસેસ કરવાના છે અને લુક ફોર ઇન કે ભાઈ બીજું કોઈ વસ્તુ નવું ડેવલપમેન્ટ તો નથી. સો ઓલવેઝ ઇફ યુ આર નોટ ગોઈંગ ટુ રીઅસેસ અસેસમેન્ટનું બહુ મિનિંગ નહીં રહે તમારા ફિઝિયોથેરાપી કરિયરની અંદર અથવા ક્લિનિકની અંદર. એ તમે ખાલી આઈડિયા આપો કે આ કન્ડિશન છે પણ અસેસમેન્ટ રીઅસેસમેન્ટ વગર ઇટ ઇઝ નોટ યુઝફુલ એટ ઓલ. યસ, લુક, મૂવ એન્ડ ફીલ. હું અને રોહન સર ડિસ્કસ કરતા હતા, મેં બહુ બધી સ્લાઇડ્સ બનાવી હતી અને રોહન સર ગેવ મી ધી સજેશન્સ કે આપણે એક્ઝામિનેશન એકદમ બેઝિક ફંડામાં જ પતાવી દઈએ. સારું સર કંઈક આઈડિયા, અને સરે મને આઈડિયા આપ્યો. લુક, મૂવ એન્ડ ફીલ, જસ્ટ ફોલો ધીસ 3 બેઝિક સ્ટેપ્સ. તમારા કદાચ પોતાના બી કંઈક ફંડામેન્ટલ હશે આવી રીતના. લુકમાં ઓબ્ઝર્વેશન, ઇન્સ્પેક્શન એન્ડ પોસ્ચર. આફ્ટર ધેટ મૂવ સ્ટાર્ટ વિથ એક્ટિવ રેન્જ ઓફ મોશન, પેસિવ રેન્જ ઓફ મોશન, જોઈન્ટ અસેસમેન્ટ એન્ડ ફીલ, રેસિસ્ટન્સ ટેસ્ટ અને સ્પેશિયાલિટી. લાસ્ટમાં ફીલ, પાલ્પેશન. ઓકે, સો ઓબ્ઝર્વેશન. ફર્સ્ટ થિંગ લાઈક આપણે ક્લિનિકમાં પેશન્ટ્સ આપણે ત્યાં આવ્યું અને યુ હેવ આઈડિયા કે પેશન્ટ ગેમ્પિંગમાં આવ્યું તો કદાચ લોઅર બોડીમાં કંઈ પ્રોબ્લેમ હશે, થોડી મૂવમેન્ટ ઓકવર્ડ હશે, આમ સ્ટેબિલાઇઝ કરીને આવ્યું તો અપર બોડીમાં પ્રોબ્લેમ હશે. સો જસ્ટ ટ્રાય ટુ લુક હાઉ awkward their posture is or how they are stabilizing their body parts, how they are sitting. Inspection, look for the swelling, discoloration, edema, any obvious deformity, redness, atrophy and hypertrophy. No palpation in the beginning as it can irritate the structures. Expose that area and ask the patient to wear loose fitting clothes. અમારા ક્લિનિકમાં તો કદાચ જેટલા બી મેલ પેશન્ટ આવ્યા હશે અને જેની અપર બોડીમાં કંઈ પ્રોબ્લેમ હશે હસબન્ડની કોઈ બી, તો આઈ આસ્ક ધેમ ટુ રિમૂવ ધ ક્લોથ્સ લાઇક શર્ટ ઓર વેરિંગ ધ શોર્ટ્સ ટુ ડાયગ્નોઝ. ઘણી વખત આપણે શર્ટમાંથી નીકળતા હોતા અને વી ડોન્ટ નો કે સ્વેલિંગ ડેવલપ થયું છે કે નથી થયું, બરાબર ને? એટલા માટે થોડું સ્ક્રીનિંગ કન્સલ્ટ પ્રોપરલી કરશો તો થોડો સમય લાગશે તમને લોકોને. ઓકે, પોસ્ચર, ડોન્ટ લુક ફોર ધ સિમેટ્રી. ઇટ ઇઝ જે આપણે લોકો સેકન્ડ યરમાં ભણ્યા ફર્સ્ટ યરમાં ઇટ ઇઝ નોટ લાઈક ધેટ. હવે બધું ચેન્જ થઈ ગયું છે. સો ડોન્ટ લુક ફોર ધ સિમેટ્રી કે આ શોલ્ડર થોડું ઉપર છે, આ શોલ્ડર નીચે છે, ક્લેવિકલ બરાબર નથી. ઇફ યુ આર લુક ફોર ધ સિમેટ્રી then you are on the wrong path. Look for the static as well as dynamic posture. Yes, it is important. So for example, somebody, you are observing the scapula from the posterior view and ઘણા લોકોને even static scapular winging બી જોવા મળશે. તો કદાચ એ તમને આઈડિયા આવશે તો you will completely know કે કદાચ આને dynamic scapular winging 100% હશે જ. We'll learn how to observe that. So look for both static as well as dynamic posture. Static posture will sometimes give you the idea if it is a severe muscle spasm હશે અને પહેલા પોસ્ચર આવું ન હતું તો કદાચ is a new development. Posture doesn't tell you everything, but yes, it is a base you have to observe. This is my method. Okay, ideally proven method નથી આવડી. Feel comfortable, shoulder width apart. So I always ask the patient કે તમે અહીંયા ઉભા રહી જાઓ normally. It is not necessary કે તમે પગ સીધા કરી નાખો, ideally ઉભા રહો. તમે રૂટીનમાં જે પ્રમાણે ઉભા છે એમ જ ઉભા રહો. Some extra rotation or maybe this posture. and then ask them to close their eyes. Okay, be relaxed, breathe in 2 times, 3 times, depends. If the patient relaxed, then start observing their posture. So ideally is you give the command to complete an exhalation karna ko, be relaxed, and then close your eyes. What's your open nahi karwanu. Then observe. Yes, but when you are closing the patient's eye, તમારી પાસે બહુ સમય નહીં હોય. So ideally હું શું કરું છું, એકવાર આ patient posture માં આવી ગયું, then I have a mobile. I'll click the photos first. ભલે 5-7 મિનિટ વધારે લાગશે. And then again ફરીથી આ વસ્તુ રિપીટ કરીશ. જ્યારે next time રિપીટ કરીશ ત્યારે we'll have idea about this posture. પણ આપણી પાસે બહુ સમય નહીં હોય એ સિચ્યુએશનમાં. બટ તમે આ પ્રમાણે કરશો then you will have a you don't need a much time. ઓછા ટાઈમમાં તમે પ્રોપર વસ્તુ ઓબ્ઝર્વ કરી શકશો. So ideal I think તમારે બી આ વસ્તુ એક્સપિરિયન્સ કરવી જોઈએ ક્લિનિકમાં. Close eyes, inhale, complete exhale. Once you find the patient is relaxed, be in the same position, no need to breathe more. Take a pictures, all the like anterior view, posterior view, both the side views. And yes, તમે જે observe કરતા બધું જ observe કરી શકો છો. So ideally, if you're asking me to observe, like out of topic બોલું છું થોડું વધારે, asking me observe the posture, તો હું forward બહુ ઓછું observe કરતો હોઉં છું. કદાચ athletes માટે shoulder symmetry observe કરતો હોઉં છું. I observe between the distance between the upper body and trunk on both the side. કદાચ knee-માં કોઈ valgus verum or fit થોડું જોઉં છું. Upper body anterior view માં આટલું જ જોઉં છું. Posterior view માં mostly scapula level observe કરું છું. I even sometimes mark the scapular border, inferior angle and supramental angle. Back બહુ ઓછી until કોઈ asymmetry જોવા મળે તો, અને પાછળથી ફિટમાં calcaneal valgus observe કરતો હોઉં છું. અને સાઇડ વ્યુઝમાં ખાલી બેક ઓબ્ઝર્વ કરું છું અથવા તો હાઇપરએક્સટેન્શન ઓફ ની, જસ્ટ ટુ સી કે વધારે કોઈ લંબાર લોડોસિસ સિવિયરલી વધારે નથી અથવા તો થોરાસિક કાઇફોસિસ વધારે સિવિયર નથી એટલા માટે. બાકી એથલીટના તમે પોસ્ચર જોશો તમને આઈડિયા આવશે કે nobody is proper posture. Even they are muscular bulky, but they don't have a proper posture, and it is helping them with their sports. Okay. દેખાય તમે લોકોને if somebody is તો practical તો દેખાશે કે લાઈટ ચાલુ કરો. Okay. एक साइड में सर so active range of motion so હું always patient આ પ્રમાણે કહું છું કે try to perform the same movement which I am performing actively. We are observing the right shoulder pain, so go for the flexion up, try to look for the movement, look for the facial expression, or whether while performing the movement is stopping somewhere and then he's performing the again. Okay, abduction is simple. In sideways you can ask him to perform. ઘણા બધા પેશન્ટ એવા હશે કે જે લોકો અબડક્શન કરતા એમને આઈડિયા નથી હાઉ ટુ પરફોર્મ ધ મૂવમેન્ટ, સો દે વિલ ગો વિથ ધીસ મૂવમેન્ટ. હું જસ્ટ ખાલી હિન્ટ આપી દઉં છું કે તમે 90 ડિગ્રી ઉપર પહોંચો પછી થોડું રોટેશન કરીને ઉપર જોજો, બરાબર. દેન સ્કેપ્શન, ઇટ ઇઝ ધ સેમ મૂવમેન્ટ. You can ask them to perform in a both way together also. Okay. Then functional external rotation. So you can observe from the front as well as from the back side. So back side, touch your upper back. Okay. હું મેં સિમ્પલ મારા એથ્લેટ માટે આવું કરી દઉં. હું જ્યારે કહું આમ સમજાતું તે લોકોને કે રાઈટ અપ so touch up and left down so touch here. So એમ જ કમાન્ડ આપીશું બી. રાઈટ સાઈડ અપ, down, left up, down, right down, okay, and left down. Okay, so basically આપણે રોટેશન જોતા હોઈએ છીએ તો એ ક્રાઇટેરિયા એવું કહે છે કે ખાલી તમારું રેડિયલ ડિવિએશન ના થવું જોઈએ રિસ્ટનું, so try to keep them neutral, અને ખાલી ઇન્ફિરિયર એંગલ શું સ્કેપ્યુલા સુધી આવી જાય તો ઇટ ઇઝ અ નોર્મલ રેન્જ. ઇટ ઇઝ નોટ નેસેસરી કે તમે એને ઉપર ખેંચીને એ સુધી લાવો. ફિમેલમાં થોડું વધારે જોવા મળશે તો જેની હાઇપર મોબિલિટી હશે એ લોકોને થોડું વધારે જોવા મળશે. Okay, and relax. So that is functional external rotation. This is functional internal rotation. Observe scapular movement for the dyskinesis, scapular posture, and shoulder posture. And remove shoulder. હું ક્લિનિકમાં હું કંઈ હોલ્ડ કરવા માટે નથી આપતો. 1.5 kg or 1 kg નું જે વેઇટ કપ હોય એ હાથમાં બંને હાથમાં આપી દઉં છું. So you can ask them to hold dumbbells. પણ એ સ્કેપ્યુલર વિંગિંગ માટે તમારે એક્સેસિવ વેઇટ 5-6 કિલો સુધી જોઈતું નથી. 1.5 કે 2 kg enough છે, depends on the patients. Okay, so observe from back side. હું વિડીયો બી લઈ લઉં છું નાનો. So stand straight, try to perform movements together. So first movement is flexion, the next one is scaption, middle angle, the last one is abduction. Try to rotate. Okay, first flexion, complete up and down. Okay, so when he's going down, try to perform the movement slowly. Take it up, up, up. Slowly down, slowly down, slowly down. You can look for the winging. Starting either types 1, type 2, type 3. Type 1 is about inferior angle, type 2 is about middle border, and then superior angle. But according to me, હું ખાલી winging observe કરું છું, કોઈ બી angle હોય, whether it is inferior, middle or superior. એકવાર થ્રો વિંગર થયો, it is scapular winging is confirmed. I don't divide type 1, type 2, type 3. Just તમે યાદ રાખવા માટે કરી શકો છો. So first one is flexion. It is very necessary to even include કે flexion માં winging થયું કે કઈ movement માં થયું. The next one is scaption. Perform it normally, take it up, bring it down slowly, bit slowly, down. And third one is abduction. And down slowly. So मैं ऑब्जर्व કર્યો પ્રમાણે abduction માં સૌથી વધારે વિંગ થવાનું compared to flexion and scaption. Okay, then look for the shoulder posture, scapular movement. હું obviously પેનથી માર્ક કરું છું inferior angle of shoulder, middle border, and then superior angle. I'm looking for the any kind of kyphotic curve over here. Forward and હું એટલું observe નથી કરતો, પણ thoracic kyphosis અને lumbar lordosis હું ખાલી observe કરું છું. Thoracic kyphosis મેં કીધું પ્રમાણે if somebody is through kyphotic curve, and then we have to ask him to look straight and ask him to perform the movement actively both the side. You're not able to reach the end range because of this curvature. Even out of topic, frozen shoulder ઘણા બધા cases ની અંદર even આ વસ્તુ બી observe કરવી જોઈએ અને try to involve thoracic mobility in the GF protocol. Next one is passive movement, flexion, abduction, horizontal reduction, internal external rotation. So always ask the patient to be relaxed. Always start with on inward side. હું ખાલી ડેમો માટે કરું છું. So be relaxed, look straight. મારે બહુ વાર પેશન્ટને કહેવું પડે look straight, because whenever you're performing or whenever as a physiotherapist or patient is doing some exercise in sideline, they always try to look કે બરાબર થાય છે કે નહીં, sideline abduction. So always straight કે તમે કશું નહીં કરો, તમે સામે દેખ્યું. સામે બહુ વાર કહેવું પડતું હોય કે સામે દેખો, look straight. Just perform simple passive movement of forward flexion. You can work on the flexion, sideways abduction. You can work internal rotation, external rotation at around 90 degree. And start with around 30 degree. Ideally is 90 degree. Be relaxed. The next one is perform elbow flexion, extension. Hold the grip. You can perform supination, pronation. Hold the grip. Wrist flexion, extension. Hold the deviations. Okay. These sports player તમે observe કરશો, then you will feel some kind of tightness on the right dominant side. એટલે જે લોકોનું supination, pronation થોડું restricted જોવા મળશે તમને compared to other side. Look for range of motion, pain and end-field. Always try કે તમે બહુ એકદમ પાછળ નહીં ઉભા રહો. Try to stand on a sideways. જ્યાં જરૂર પડી ત્યાં કદાચ પાછળ ઉભા રહેવું પડે. Observe the patient's facial expressions. અથવા એમને પૂછો બી ખરા કે આ જો ફ્લેક્શન કર્યું એમાં પેઇન વધારે થયું હતું કે પછી આ મૂવમેન્ટમાં વધારે પેઇન થયું હતું. ઓકે, એન્ડ કોરિલેશન ઇઝ નોટ ideal right now. Then your examination whether it is in correlation or not. If active range of motion is restricted along with passive range of motion, it is a mobility issue. So the patient ने किधु के flexion तमे करो एमने ना करियो आटला अटकी गया था અને then you did the passive range of motion and it is the same range or थोड़ी વધારે, that is a mobility issue. બરાબર અને પેશન્ટે હિસ્ટ્રી કીધી ડાયાબિટીક છે છેલ્લા 10 દિવસથી વધારે કોઈ સ્ટીફનેસ ફીલ થાય છે then it is ideal કે કદાચ એડિશનલ કેપ્સ્યુલાઇઝમાં ખુદનો જોડે હોઈ શકે બીજી બધી હોઈ શકે એક્ટિવ રેન્જ ઓફ મોશન ઇઝ restricted but passive range of motion is completely normal તમે એક્ટિવલી કીધું he was not able to perform more than 91 degree પણ પેસિવલી એને completely પૂરી કરી there is issue with rotator cuff or any kind of muscle pathology could be a rotator cuff tear sometimes inflammations થાય તો બી inflammation will shut down the muscles અને એના કારણે muscle inhibition જોવા મળશે અને આઈડિયલી મૂવમેન્ટ નહીં કરી શકે પણ ઇન્ફ્લેમેશન ઓલરેડી આપણે લોકોએ ઓબ્ઝર્વેશનમાં ઇન્ફેક્શનમાં ઓબ્ઝર્વ કરી નાખ્યું છે અને કુડ બી પુઅર સ્ટ્રેન્થ ઇન જનરલ જો તમે ન્યુરો કેસીસ કે બીજા મલ્ટિપલ કેસીસ જોતા હોય તો એન્ડફીલ એટલા માટે કામમાં આવશે કે જ્યારે once you are dealing with cases of stiff shoulder whether it is pre-operative or adhesive capsulitis or post-operative એન્ડફીલ plays a very important role okay અને આપણને કોન્ફિડન્સ બી આપશે if you find કે I'll explain bony and hard Enfield that is elbow extensions કદાચ તમે કદાચ ફીલ કર્યું હશે soft tissue approximations elbow flexions and knee flexions and a tissue stretch shoulder external rotation shoulder elevation and dorsiflexions abnormal Enfield empty that is from pain you're not able to touch the complete range patient withdraw due to pain spasm or muscle guarding prevent the motion or pain shoulder external rotation maybe tightness of any capsules block hard block in a range of motions it can be a loose body soft block can be a knee flexions sometimes of meniscus case even post operatively if you are going for elbow stiffness creation if you are going with capsular Enfield or some kind of tissue stretch then patient confidence આપી શકો છો કે ચિંતા ના કરો આ જુઓ તમારું Enfield is very soft you will achieve the range within 10 days or few days okay so nothing to worry ligament laxity sportsમાં this is very important generalized ligament laxity એનો એક સ્કોર હોય છે Brighton score if I have an athlete whether he is suffering with any kind of knee injury ankle sprain any kind of shoulder pathology or anything એનું જે pre participation screening હશે એની અંદર we always work on this it is a Brighton score so start with hand thumb to forearm 1 you have to give a good scoring system compare with the other side 2 next one is little finger don't have to press much can it pain થાય if you find this stiffness in the આગળ વધતું નથી you have to press but if you are about to reach થોડું તમે press કરીને just try કરી શકો છો okay the next one is little finger ideally should cross the 90 degree without any stretch the next one is elbow extensions so 1 2 3 4 the next one is elbow extension flexion go for extension yes can go for sideways next one is elbow extension try to compare with other side next one is knee knee extension તમે couch ઉપર જોઈ શકશો just ankle થી હવે ઉપર કરો or you can ask them to push back the next one is touch the floor look straight and touch the floor is able to touch now here ઘણા બધા criteria આવતા હોય છે okay look straight now he has to touch the floor with his hand sometimes it is not possible but it doesn't mean કે patient hypermobility નહીં હોય શકે કદાચ એની backની stiffness એને allow નથી કરતી but he is hypermobile but yes you have to as a scoring system you have to give 0 for this back okay so there are 9 criteria on 9 scoring system 5 થી વધારે cover થાય then they have a hyper ligament laxity or generalized ligament laxity so તમારો આખું rehab એ પ્રમાણે change થઈ જશે if you are treating any patients with post operative ACL repair and the patient has a ligament laxity your rehab will change it is not the same rehab which you are going to perform on all the patients chances of instability are higher મારા ત્યાં 14 વર્ષનો કોઈ છોકરો આવ્યો હોય અને ligament laxity પોઝિટિવ હોય છે એની મમ્મી એવું કહે કે એને સ્પ્રેન તો અત્યાર સુધીમાં 5-7 વાર થઈ ગયું છે પણ આ દરેક વખતે વિધિન 3 ડેઝમાં ઇઝ બેક ટુ કોર્ટ that is not a good sign so now whether he has a currently ankle sprain or not you have to check all the ligament or laxity or tenderness and if determines then start the rehab even though if there is an ankle sprain nahi hoy to be prevention માટે you have to start the rehab as early as possible it is because it is not good sign is already ligament laxity અને એની ઉપર 5-7 વાર ankle sprain ની history છે repeated, it is not a good sign. Muscle testing. Weak muscles cannot stabilize. Work on the baseline strength. Perform, if possible, isolated manual muscle testing. Already આપણે લોકો third year માં cover કર્યું છે આ વસ્તુ. Just one technique. Proper positioning of patients or particular joint. Ease in, push, ease out. Over here, we are not trying to win the patients. Okay, it is not about our strength and patient strength. So if patient is standing there, and I am performing some, for example, full can test, and I know that he is younger than me, કદાચ એની strength મારા કરતા ઓછી હશે કદાચ. I don't know about him, કદાચ ઓછી હશે. So I don't have to win him. I don't have to apply. Hold it. Give at least 2 to 3 seconds of time. Don't create a jerk. It will increase the pain as well as it is not a good sign. Somebody will imprison 40%. Just push, hold it here, hold, relax. Once he is relaxing, try to leave your pressure. So hold this way. Don't do like this. Hold the here. Hold. It's not a good way to check the manual muscle testing. So hold the position for at least few seconds, around 2-3 seconds. Command the patients, and most important, don't try to win. We are not trying to prove the pain કે તમને આમાં pain થાય જ છે. Okay, otherwise નહીં હોતું બી આવી જશે એમને, આપણને બી આવી જાય. Assistance examination. So flexion. Try to keep your elbow straight. Either you can perform along with the movement or at some angle. Okay, it depends what you want to check. For example, flexion. Take it up. Or I'll ask him to hold at 45 degree, hold it, around 90 degree, hold it. Then abductions, specifically for the deltoid, I use this method, make a fist, take it up, around 50 degree, whether it's painful or not, around, hold 45 degree, check it again, hold 90 degree, check it again. Then for the anterior fibers, for this way, pick it up, hold it. Posterior fibers, go bit oblique, and okay. Abduction and adductions, then internal external rotations. You can observe even in supine position, standing, hold it. Try to move outside, do it. Good. Try to move inside, hold it. Okay. Elbow flexion, either along with the movement or at some angle. Flex. Hold here. Relax. Elbow extensions, from flexion. Okay. Look for the pain and or weakness. If there is a pain but no weakness, if there is a pain, my test for and the pain for full weakness or the full can, empty can. So is again. It can be some kind of tendon issue, particular muscle issue. Right? Pain with weakness. Pain big and you was not able to hold properly. Sometimes specifically I have to check out pain with the weakness. As the patients get very no pain, I can try to hold with the strength just to rule out कोई dead तो नहीं. So he's holding and I'm trying to press to pain तो मैंने छोड़ दी तो बीच में खाली कमांड आपी एक बार खाली प्रयत्न करो ना कि proper strength आवे चाहिए तुम्हारी. Even though it is painful, just try to hold. Okay. So pain with a weakness is a sign of tear. You can categorize according to your experience or investigations. Weakness without pain, it can be neurological conditions, it can be a muscle inhibition, it can be any sport-specific weakness. When antagonists and agonists work out, because of pattern, some muscles are very strong compared to other things. Okay, but first to try to compare always pain with a no weakness and pain with a weakness. Special test. Again, examination day portions के जाने पर आपने जल्दी jump करना होगा. So we always want to talk about special tests. Treatment are often structured around the functional deficit we find versus structural pathology we find. We should do both the things. Try to find the symptoms as well as the cause. Don't forget, they often help us to determine what not to do as much as what to do. you are performing all these active movement, passive movements, resistance stress, ligament laxity, then your basic conclusions ke mara rehab ma which movements I have to avoid. Okay. Most importantly, to learn and perform the repetitions. Special test book માં વાંચવાથી, YouTube માં videos જોવાથી આવડી જશે ખરા, પણ you are not able to, even for us also it is not a perfect way. The more you see the patients, the more you do the ideal examination, the more you are near to the good quality of conclusion or good quality of diagnosis. It doesn't mean you have to do the same diagnosis on the same day. If you find like patient has a more pain, our test positive आया तो write down the test, बाजू में खाली क्वेश्चन मार्क કરી દો for your knowledge કે આ મારે કદાચ 3 દિવસ પછી થોડું ઇન્હિબિશન અથવા ઇન્ફ્લેમેશન ઓછું થાય પછી રિપીટ કરવાનું છે. So just a small question mark and you have to repeat the test. Okay. Now I have covered only basic pathology. Structural injury to rotator cuff. It does another among signs and symptoms આપેલા છે. It doesn't mean that patients will have similar features or similar signs and symptoms. Patient will vary, depend on the conditions, depends on the involvement, depends on the more the chronic case, the more involvement you find. So for example, ideally હું એવું કહું કે કોઈ બી પેન આપણી બોડીમાં 2 વીક કે 3 વીક, ઇવન તમે તમારા પેશન્ટ્સને બી કહી શકો છો 2 વીક કે 3 વીકથી વધારે આપણી બોડીમાં રહેશે, then it will try to create some kind of compensatory changes in and around muscles or joints, જેવું pain. So the more patient તમે history કાઢી પેન ક્યારે સ્ટાર્ટ થયું હતું, before 2 months, so it is ideal કે કદાચ compensatory changes ઘણા થઈ ગયા હશે 2 મહિનામાં. Okay, so structural injury to rotator cuff, more than 40 years of age, કદાચ કોઈને બી થઈ શકે છે. 60 years with shoulder pain can be presumed to have rotator cuff tear, but yes, ideal તમે examination કર્યા પછી જ તમે conclusion આપી શકો છો. Younger patients will have irritations of rotator cuff. It can be any kind of tendon pathology, tendinitis or tendinosis. Mostly insidious, if not traumatic or acute overuse. Night pain always rotator cuff patient was જોવા મળતું હોય છે. Yes, if you want to cover or if you want to find out whether તમે કોઈ case જોયો, if you want to cover whether it is mild, moderate or severe. So for example, shoulder માટે એક નાનો question or scale you can say. So whether patient has a night pain or not, whether the pathology is radiating down the elbow or not, and the third one is whether the patient has a wrist pain or not. If they don't have any of three, then the condition is you can categorize it between mild or mild to moderate. Okay, and if everything is here, then it is moderate to severe. Okay, so night pain, not able to roll on the affected side, find the relief. Affected arm overhead with the hand behind the head. Pain minimal below chest level and maximum between 90 to 120 degree. Inactive, elevation or flexion or abduction. Lowering the arm, drop arm test from overhead positions will be more painful. Patients may describe crepitus, which is associated with chronic full thickness tear or thickening of cuff during the chronic tendinosis and scarring of subacromial space. Ideal test depends on the experience. Full cane, empty cane. So, as the patient will stand in front of you, for this movement, you have to hold it and apply downward pressure. Okay, this is full cane. Hold it, hold it, hold it. Empty cane, same ideal position. You try to go with just in the movement guide karo. Go with proper movement because ઘણા બધા પેશન્ટમાં તમે જોવા મળતો હશે once they are in this posture એમની આખું posture બદલી જશે. Full cane, then they have empty cane. So if you find something is wrong over the shoulder, just try to guide the movement. Hold this position, hold it, not hold it there. Look straight, hold, hold, hold. Okay. Drop arm test, patient should be in a sitting or standing way. You can work with abduction over here, bigger fist. Try to hold it, hold it. If he is able to hold, negative. If he is dropping, not able to hold, positive. But over here, I always say that if your it is 120 degree, try to hold the here. I'll keep my hand over here because I don't want him to fall down and again exhibit the pain. Okay, so drop arm test. Lift off test. Patient should be from the back view. Mid-back area. First sign is ask them to take away the hand, whether it is possible or not. First sign. If it is not possible, test is positive. If it is possible, over here, please again don't try to win it. 2 fingers is enough. So hold it away, look straight there, hold away, hold it there, hold, and enough. Okay. Third one is the leg side. Ask the patient to hold the test over here. If he is not able to hold, falling down, test is positive. Belly press test, always you always go with quality or strength over here. So you have to press your hand over here. Do it. The next one is bear up test. So put it over here, elbow around 90 degree of flexion, and ask the patient to press the opposite shoulder down. If it is positive, test for the subscapular is positive. External rotation is for infraspinatus. So there are some leg signs 30 degree away, or you can ask the patient to hold here. He's not able to hold, test positive. If he's able to hold, the next one is sideways. Look for the trunk and elbow distance. Apply the pressure on outer side. Do it. Compare the movement, compare the quality of test or strength with opposite side. Glenohumeral instability, mostly younger age, in elderly, associated with massive rotator cuff tears, traumatic events about and 3% subscapular. Medicines are necessary to control the symptoms or discomfort.
I think Ronak will continue the further examination after the break. I will invite Dr. Chaitsi Mehta, who is head of the medical services of Zydus Hospital. She will introduce her and then we'll take a break of around 15-20 minutes and we'll come back again.
Good morning, everyone. I know everybody needs tea, but just give a louder good morning. Thank you. So, we will take a break of around 20 minutes. Is that all right? 20 મિનિટ enough છે ને ચા કોફી માટે? કારણ કે જો આમાં કલાક લગાડશો તો જમવામાં કેટલા ટાઈમ જશે એટલે. So have some refreshments. I officially wanted to welcome you all on behalf of Zydus Hospital. Thank you so much for taking time out on this Sunday and coming here. We are excited to begin this as a series of many events with Dr. Rohan because I always feel that not enough rehab specialists have been here before, and we'd like to invite all of you in a cyclical way. But for now, before further ado, we'll talk a little bit more after the break once all of you are re-energized and you have some juice inside. Go outside, there are refreshments and there are some cookies as well. We will have our break for now for 20 minutes, then we'll have some sessions, then we'll have lunch around 2, and then we'll have some more sessions. So you can go have some tea. Thank you so much, everyone.
થઈ ગયું હવે થશે થઈ જશે હવે